more of the official duties of the day. So our first speaker, Dr. Angela Lin, needs little introduction as she's an integral part of the foundation as the co-director of the Myhre Syndrome Clinic at Massachusetts General Hospital and chair of our professional advisory board. Angela is a board-certified pediatrician and clinical geneticist who also trained in pediatric cardiology, including a year at CHOP in 1986, which I'm not sure I believe, because that can't be true, right? She's dedicated to caring for people with physical differences, especially syndromes involving the cardiovascular system. She is active in numerous research projects and has published over 100 articles, the latest of which is an incredible look at the emerging trends of Myhre syndrome from the many years that she's been following Myhre syndrome patients in the clinic. And you might have seen printouts in the foyer as well, so we encourage you to take one. Angela has been integral to the lineup of incredible speakers we have today and reached out immediately to her colleagues to make this event happen. So please join me in welcoming her to the stage.
Good. Thank you so much, Kate. Thank you, everybody. Many of you I know as patients, many of you I know from your stories, and even those that I don't know. It's just really wonderful to be here. As you know, I'm kind of a huggy person, so expect those little hugs, sometimes the fist bump. My role model in medicine is actually not Francis Collins or James Watson, but Oprah. And I just love the way she connects, and it's always sort of been my inspiration. So this is my talk called Myhre Syndrome Potpourri, and let me know if you can hear me okay. And I'm entitling it Patterns, Phenotypes, Providers, and Predictions. I tend to be a fast talker because I really want to get this all in. Let me know if I'm going too fast, Kate, maybe. And so I have to disclose that I work with the Myhre Syndrome Foundation. I'm on the professional advisory board. We're going to be renaming it the medical advisory board. I'm a consultant. And with gratitude, I thank the foundation for half of the support for our wonderful research assistant, Maggie Brand. I work as an editorial board for the American Journal of Medical Genetics. I'm a clinical geneticist, also in public health. And the photos you're going to see were either provided with consent from many of you parents, or they're from sort of the public domain. So this is dedicated to you, because you guys are my teachers. Technically, I'm up here at the podium, but everything I've learned, I really learned from you, either reinforcing things that I've guessed at or things that I have missed, and you've taught me about that. And so we're going to do just like 2 slides for the basics, okay? Because the other speakers are going to expound on this. So this is rare, you knew that. Increasingly diagnosed, you knew that too, and distinctive. And it's caused by variants in a gene that's so easy to say, SMAD4. But stay tuned, because Dr. Lois Starr is going to have the next talk to talk about genetics. Broad spectrum. My hands can't go wide enough to talk about the different people that I've met in terms of their appearance, their abilities, and their challenges. And the natural history means that we're learning over time. You know, a perfect study would be to take 100 people with Myhre syndrome, follow them for 50 years. Not going to happen, right? So what I'm going to refer to is the fact that Bert and I, who've written papers that are called natural history, we call them emerging, because it's going to take some time to figure it out. And the way doctors do things, it's not just based on our personal experience. We follow guidelines. We call them evidence-based guidelines. And Bert and Lois and I are going to start to work on them actually tomorrow morning. But for now, you can use the table in my paper. So clinical features. And I preface this by saying in many, but not all, right? So we usually have small size at birth, but not everybody. There's usually a characteristic face, but it changes over time. There's usually hearing loss, the need for glasses. And this is a wonderful montage prepared by the mother of one of my patients, April Lenord, and this is her son, Alec. They've given me complete, in fact, April created this for me. But what it shows you, and I'll see your heads nodding, the face and the appearance does change over time. Talk about that a little later. And briefly, the cardiovascular, we think about the aorta, the heart structure, the heart defects, the heart sac, the pericardium, the heart muscle, which is called the myocardium. We think about brain health and wellness, learning challenges, autism, social disability, and mental health. Breathing, the large airways all the way down to the lung, and connective tissue, joints, rib cage, skin and tissues, lining of the heart, lung, and abdominal cavity, they all count. And other speakers, as you can see from your program, will be speaking about specific topics, starting with Lois. We have neuropsychology, we have a research update, cardiology, cancer, gynecology, airway, and the immune system as well. So you're going to say, well, what else? Well, Kate did that. And she said, Angela, you're going to do everything else. Whoa. So brain, spine, psychiatry, vision, hearing, mouth, facial structures, GI, nephrology, urology, skeleton, and skin. So understandably, I will probably be speaking quickly. And my goal is just to sort of cover it and move along. It won't be as in-depth as some of the other talks. And I just want to reference that this is what my paper looks like. And we have reprints for you, one per family, and they're out on the table. But notice how we're focusing on several papers. So mine is not necessarily the end all or the be all. It just represents MGH. But there was a paper written by the group in France. The first author is Yang, and the senior author is the very distinguished Valérie Cormier-Dare. And then this is Bert's paper, which focuses on Bert and Eva's paper, which focuses on the adult. And because this is a rare disorder, there's always overlap. And we try to call attention to it. There's certain patients who are reported twice, and that is just the nature of what we deal with. So you might be thinking, is MGH similar to CHOP, the University of Nebraska, Ghent, Paris, Naples, London? And the answer is probably very similar. We have some regional differences related to access of care and funding. That is the single biggest difference that I've learned about. And you might see somebody or hear something and think, is she talking about me? Maybe, but I will not disclose any names. Any pictures that are there are people who have already consented. You might recognize yourself. What about my child? What about me? There are always exceptions, and people are unique. And I'm sure each of you has a story or a child where there's one feature that we haven't covered. Will things change? I will say absolutely. I will quote myself. I will say that I wrote in a letter, some form of social disability, autism spectrum is always present. Wrong. Fast forward to 2024. There are definitely people with no social challenges, although most have it. So I phrased it very carefully. And you might say, didn't somebody else talk about that already? And the answer is yes, but repetition in this scenario is good. Hopefully we'll be consistent. So I'm going to talk about what I call patterns before I launch into this. So how many of you sew? Who knows what it's, there we go. It's a dying art, isn't it, right? But as a kid, I had all these patterns and I used to do it. But a pattern also can mean something like we see in a quilt. Who likes Amish quilts? All right, you got that? And then the notion of a pattern means that you're seeing something in the context of other stuff, all right? So let's start with neurology. Here we go. Neurology is different from what you'll learn about in the learning talk neuropsychology. I'm going to go very quickly. Having a relatively large head in most, and this could be relative to the shorter stature. A small head, fewer, 6%. Structural physical defects of the brain, uncommon. We have at least 2 individuals who had something called a Chiari malformation, one of whom needs surgery. And there's something called the corpus callosum, which bridges both sides of the brain. And so this little diagram here shows you the corpus. And in this side here, let's see if we can get this going. Let's see, I think I want an arrow here. Well, anyhow, on the left side, you can see that it's labeled as normal, and on the right side, it's labeled as abnormal hypoplastic. And so that can be affected. So I've highlighted the next section. It's a little bit different. We touched on it in our paper, and this is really a specific research interest at MGH. Blood vessels are involved in the brain, very small blood vessels. There is a feature that is seen on some MRI scans, and it's so small. See those little arrows? You can hardly see them. They're called white matter hyperintensities. I think of it as a footprint in the brain. People have had these described as hypoxemia, neonatal injury. We don't view it that way. We think of it as white matter injury, that there probably was some issue with the blood supply in a very small way. Presently, good news, no correlation to intellectual disability, autism, or stroke. We do recommend now a brain MRA in all patients. I know this will come as a surprise to some people. We can talk about it later. Stroke, it's something we need to understand the risk factors, prevention, and treatment. is uncommon. When it happens, devastating, but it's something we need to think about. And seizures definitely occur, fewer than 10%, and there are various types. Just a brief mention of the spine, there is something called a tethered cord, which is a great name. Tether, meaning pull down. And we do see it. Some of the clues are a deep sacral dimple, like way deep. You can't see the bottom. A gluteal crease, which is above the buttocks. Lumbar or vertebral variation. Toe walking, which is common in autism, but this is a little bit different. And severe incontinence. And surgery has been done in 7 patients. We are doing it to prevent progression. We're not doing it to cure. We're doing it to prevent further damage later on. A little bit about mental health and psychiatry. In our series, 25% were actually seen by a psychiatrist. And folks, as you know, there's like a long wait around the country, so as much as up to 6 months in some places. There is a classification called, you hear about ICD, this is called DSM. And I bet many people will shake their head knowingly, they've heard it before. And so it can refer to this book. And we're up to DSM-5 TR, so it's constantly being revised and updated. Autism and ASD, about 70% in our study met criteria, and there are criteria. You know, the parents do a survey, the providers do a survey, the teachers do it too. But 90%, I would say, have some social challenge, some degree. This is a young lady. Her mother is watching. I'm looking up to see if she can recognize her. And she's a lovely little girl, but she's showing the familiar gaze aversion that happens in autism. So what about ADHD? At least 50%. In our study, only 15% were treated. That could be because of parental choice, access to care, whatever. Schizophrenia, rare, and I thank the mother who first notified me about this. The number of patients is not many, but it's enough to say this is part of the brain problem. Mood and depression, all can be disabling. Anxiety, uncommon, can really influence behavior. And the treatments, well, we can't cure autism, can we? But what our goal is, at least in Mass General, and this is perhaps why we are focused on medication, you try to treat the things that go around it. So anxiety, ADHD. Switching gears, talking about the eye. So having some sort of a refractive error, most kids. Astigmatism, 65%. You know, I'm using rounded numbers, right? 65%, over half. Hyperopia, so farsightedness is more common than nearsightedness. Esotropia, when the eyes deviate outward or inward. Tear ducts being blocked or narrow. Cataracts are rare. And this is, again, a special interest of what we know at MGH. We're going to talk about something called the optic nerve, back of the eye, and abnormality. In some people, and again, I have to thank the family in Boston who called this to my attention. Somebody looks in the eye, they see something, a blurring of the disc, and they say, this is something called papilledema. Rush the child down to the emergency room for a stat MRI scan and a stat lumbar puncture. And we've learned this is not papilledema. Papilledema is a sign of increased intracranial pressure. And you don't have to tell me, but I bet some people are thinking, yeah, that's what happened with our child. We've learned it is not papilledema. It is called pseudo-papilledema, or generically we call it optic nerve abnormalities. So the back of the eye is the window to the brain. Thus far, we have not made a connection. We have not seen the brain telling the eye something, nor have we seen this feature going backwards. And we just have to figure this out in enough patients before we can explain what's going on to everybody else, and we're still emerging. But this is what we're talking about. So we think of the eye as segments: anterior, the front, the back, posterior. And this is trying to show you a normal optic disc. I'm going to show you a boy with Myhre syndrome who has this very typical blurred kind of optic nerve margin. Below is what we call classic papilledema. Without too much examination, you can just see at a glance they're different. But it took my colleague, Dr. Gina Hadari, who's on our paper, to really point this out to us. So we do ask that you have an eye exam, not by just a general optometrist, but an ophthalmologist aware of this. If nothing else, it will help establish for your child what they don't have, that nobody needs to be alarmed if they just happen to look in and see papilledema. So you see, a lot of what we do is we don't cure things. We are informing, we're educating you. Go back, okay, request to go back. Oops. Sorry. Yep. It actually says going back. Let's see, let's try this. I'm going to use my, so I was going back. Yes, I could. That's right. So we'll do there. Thank you. There's my little mouse. Okay. Oh, there we go. Friendly mouse. Thank you. So let me give you a chance to linger. Okay. Technically, you're not supposed to take pictures of slides at a meeting, but I think this is okay because I'm being broadcast anyhow, and this will be available for future review. All right. And again, we'll have time to talk a little bit more detail. Moving on. So I'm going to talk a little bit about the ear, nose, and throat. In some places, it's called the ORL, otorhinolaryngology. And this will be complemented by the doctor from CHOP who's going to be talking about the lung later on. So the outer ear can be small. You guys know that, right? Ear infections can occur. And it can be a real annoying problem because they keep coming back again. It doesn't necessarily mean that the child has a terrible infection or a terrible weakness. There's all that gunk in there that clogs it up too. And so PE tubes are very common we've used them in about 50%. And I know that people have asked us or contacted us about the risk and benefit of using tubes if there is a risk and benefit of this airway problem. And the answer is, first of all, number one, you need to take care of the child. You just need to do it in as careful way as possible. And what happens is that there is a ENT doctor who's especially concerned. If you contact me, our wonderful ENT doctor, Dr. Cohen, will speak to them. And the advice is something like this. Certainly with every child, you make a decision about whether the procedure is necessary, even more so with Myhre. But if there's stuff in there, if that's clogged, you got to take care of it, all right? And so what you need to do is inform your team. It's better not to do this sort of as quick outpatient surgery. You want to let your anesthesia team know what's going on. The concern about the airway is not that one intubation causes this airway problem. We think it might be multiple, but as several mothers said, hey, Dr. Lynn, my kids had 20 intubations already. Nothing's happened. And that really resonates with me because we don't think it's a single intubation and even multiple intubations. I think it's probably something we'd call multifactorial. There might be children, I don't know who they are, who might have this vulnerability below the larynx. In fact, the original name for Myhre syndrome was called LAPS, in which the L represented laryngotracheal abnormality. So it was well known back in 1980s when it was described. Anyhow, so that's just a very brief discussion about that. And so hearing loss, very common in about 40%, so not quite half. Those of you who children have this isoleucine valine variant at position 500, about half, and about the same with the arginine. So basically, really very similar. Conductive in most can be mixed also. People don't have a pure sensory neural loss. It can be, the onset can be as young as 15 months to as old as, say, 20 years, 30 years, and the average age is 7. But I would say that having hearing checks is really one of the mainstays of Myhre care, and it can be progressive in about a third. So how do you improve this? So hearing aids in about 60%. Oh, I should have shown this. Forgive me, guys. So this is just a picture of the ear. You may have seen this on Google or anywhere searched. You have the outer ear, and that's in red, the middle ear in blue, and the inner ear in green. And these are the different structures of the ear. So the way you can treat hearing loss is with a standard hearing aid. You can use something a little fancier called the bone-anchored hearing aid. BAHA is actually the trade name. And some people actually use American Sign Language. And we endorse that because what we have learned is, at least in our series, there were people who did not have hearing loss per se, but it was the expressive problem with language. And they actually did very well with ASL. And again, it was a mother who taught me that. So inner ear anomalies are seen in about 20%. These are potentially the entities that might be treatable. I'm trying to be very general as I talk about that. So one of the entities is something called otosclerosis. So the bones are kind of fused. This is a picture sort of a BAHA up there. Sorry about that. So talk about the airway. I'm going to do it briefly because it's going to be double covered by the doctor who's going to be speaking about it later. This is one of the first papers that came out from Cincinnati, progressive laryngotracheal stenosis with short stature and arthropathy, meaning stiff joints. This is a woman described by Bert, and this was a woman who had this. She also had 2 children, so she represents fertility. She represents airway disease. This is a young lady who passed away, and a gentleman that we cared for who also passed away. And I say that with respect and fondness for the loss. This is a woman who's followed in Europe. This is a patient that we had followed, so it can be quite severe. I don't need to frighten you by showing you these. I just want to recognize that it's real. And what it's showing you here is the way you can diagnose this is by symptoms. You hear about the stridor, the airway progression, exercise intolerance. You actually see it on a scan. You can see the narrowing. You could put a tube down and look at it. I'm going to move on to a different part of the face: oral, maxillofacial, as well as dental. And so the mouth is involved. The mouth is small in most patients. The teeth are generally small and wide space. Hygiene can be such a challenge with autism. Is that an understatement? There are some children with such sensory sensitivity, you can't even put the toothbrush near their mouth. Some mothers do it themselves. Sometimes people try those little finger brushes to make that work. And facial structure does change over time. I would say most people are very similar at age 5 years. This is from my paper, and you'll see this. This column shows a variety of patients with different variants. And are they not the most beautiful children? Is that not true? You know, I'm a terrible doctor because I start my notes by saying adorable. And, you know, because are endearing, charming, because that's what we see and that's what we love. And this is just showing faces changing over time. And, you know, those of you who are in the audience, you might say, yep, that's my child, or that looks like my child. So there are some changes, sometimes a little bit more, a little bit less. So we should talk about, though, this notion of braces. So there are, in Myhre syndrome, we tend to see a narrow palate, the teeth are malaligned. Traditional braces may stimulate growth of the mucosa. So the gums get thick. And in at least 2 families, they were put on, taken off. Those cool, clear aligners, I can't use the trade name, they are easier, but they may not work as well, but you could try them. And so cleft palate, cleft lip is rare, but known. More common is something called velopharyngeal insufficiency or hypernasal speech. So somebody talks like this, you hear the airway escaping. And there can be theoretically surgery to reduce a prominent jaw, but that has not yet been performed. Moving along, GI, liver. So constipation, it's actually not 100%. When I meet somebody who says my child has none, I just celebrate because it's great. Because it's so common and we don't know exactly why. We don't know if the bowel itself is different in Myhre. Could the bowel become fibrotic? Is there a problem about transit time? And trying to keep any child on a healthy diet is really hard, but especially with autism where there can be resistance, don't we know that? And medications. So we actually have a whole program, but I bet your GI doctor does too, about medications, and in radical situations, something called a bowel clean out, which is like if any adult has had a colonoscopy, the way you prep, you take all this gross stuff and then you poop it out. That's what we do sometimes for children who are really severe constipation. Abdominal pain, yes. Difficulty swallowing, yes. Feeding difficulties in newborns. And we're starting to think about a reason why. It might be because there might be more nasal obstruction. So this is when you talk to your doctor about constipation, this is worth thinking about. How many people know the famous Bristol score? That's great, right? It's got all different food descriptions, bunch of grape, corn on the cob. So for the liver disease, we're starting to get tuned into that. There are times where somebody might need a liver biopsy, or for the other parts of the intestine, you might need scoping, top down or bottom up. We have to check the liver for fatty liver. Weight is a risk factor for these problems. And I don't say that in any way because I want people to be, quote, skinny, but we need to keep an eye on nutrition and weight. And there can be obstructions from the top, pylorus, duodenum, and down to the bottom, rectal. Nephrology and urology. So nephrology refers to the kidney. Urology refers to the external genitalia. High blood pressure, which is kind of with heart too, about 40%. It's usually related to some interaction with the blood vessels and the kidney. Treatment, a variety of drugs. There's losartan. I won't even say them. Each of them have been used anywhere from 10 to almost 20%. It depends on your region. It depends on the doctor, but these are used. Undescended testes, almost half. Hypospadias, uncommon. Urine incontinence, at least half. And boy, it can be prolonged into older age. Urinary infections, usually not that common, and kidney stones in 10%. Orthopedics includes a variety of things: muscle, bones, and joints. So a skeletal survey has been done, in our experience, in about third. I don't know what Bert does. I'm not so sure how much value it is because a lot of the things are small. Short fingers, curved fifth finger, bent fingers, syndactyly, webbing, overlapping toes, 11 ribs, fracture, scoliosis. That's the most important thing that we want to know about scoliosis, curvature of the spine. And there can be these tiny little bone masses called eyelids, and that's webbing of the toes, syndactyly toes 2 and 3. Leg pain is common and really frustrates me because we don't know what causes it, and thus we don't know how to treat it. So the possibilities are, could this be reduced blood vessel supply? If this aorta does get small, is it not supplying the muscles? Could there be some fibrosis? Could it just be deconditioning, kind of being out of shape? Could it be that the spinal cord is somehow tethering down and influencing that? Stiff joints, really everybody, 95%, and then severe contractures are progressive in at least 10 and probably more. But they're generally mild, and that's why we do work at MGH with RPT. We've always been concerned, could this exacerbate contractions? We have not observed that, and our goal is maybe to keep people as loose as possible. And so losartan, there is a theory that if losartan does work for the heart, could it work more broadly? Could it work for joint stiffening? It's a trial that has been undertaken briefly in Naples, and I think there's going to be one undertaking in Europe, and I'll just leave it at that. The skin involved in most people, usually firm, kind of bumpy, keratosis, can have abnormal scars. They can be not only thickened, but also just kind of weird. And it was a parent again who said, why does my child have these weird scars? They're white, they're little, they occur with the slightest, scratch. And they look at the head shaking. And so we don't think it's causing any problem, but it is a marker of this dysregulated, abnormal cell proliferation. And you can also get stuff like warts, peeling of the feet. In males, alopecia, hairiness, hirsutism, skin cancer, so far no risk, increased risk. And down at the bottom in little print are all the things that have occurred at least once. So a lot of things do occur. And I think I'm almost done. Some of you out there are thinking, but you didn't mention Dr. Lynn, and you're right. And I'm saying some of the articles will have it. Gene reviews, something that Lois and I worked on, 2022. Videos, the Myhre Syndrome Foundation videos are outstanding. The website is outstanding. When I onboarded, oriented the new research assistant, I said, sit next to me. We're just going to go through the foundation website. We went through nearly every module, and it was all there, Kate, it was all there. And so be thinking ahead to 2026 where we can pick up some loose ends. So the big picture, it's not just a farmhouse in Omaha, I found this, or a house in Ghent. It's this big universe. So as you're thinking about all these little things, this is how I have to think, is putting it all together in a big picture. And this is what I call phenotypes. I'll just zip through these. The phenotypes is heart and blood vessel, not just aorta, not just myocardium, putting it all together. Aorta looks like a candy cane. There's a top and a bottom, and it can be abnormal for sure. And you're going to hear more from Aaron. The cardiovascular phenotypes, and this is more to my colleagues. We think about these distinctive phenotypes in Down syndrome, trisomy 18, the rasopathies, Williams syndrome, Lois Dietz, Marfan, DeGeorge. And I really think Myhre deserves to be on that list. I think that it's distinctive enough. What about the airway and lungs? So we're talking about that now. It involves the top of the airway, which is called the choana, all the way down to the little air sacs. And also the outside, the rib cage, which is a bunch of joints basically, can be as stiff as sort of the long bones too. In the brain, this neurovascular phenotype, this is really our interest at Mass General. We call it a cerebral microarteriopathy, white matter injury. I've mentioned these things. This is a name that you are allowed to contact. This is Patty Musolino. She really is an expert in this in many different syndromes. See, what makes the professional advisory board kind of experts is we do a bunch of stuff and we bring it to Myhre. So Bert, connective tissue, Lois, connective tissue, my friend over there, Mercedes, cancer. And so we bring it here. And so Patty is a neurologist. And this is her email address, P. Musolino, and it's like mine at mgh.harvard.edu. She actually conducts research. She has enrolled at least one person who I think is in the audience, even though they're not at Mass General. Fibrosis of the skin, I've kind of tied that together and showing you some more pictures there. Behavior and learning. Myhre has a neurodevelopmental problem, and we've tried to parse it out into different ways. There are things that are not there are entities that are not on this slide because I'm waiting for confirmation. Like you, I hear things through the grapevine and I hesitate to document them until I know more. But why are we doing this? It really helps to pull things together so we have therapy targets. So the thing about Myhre syndrome is you didn't know the good news. We have a gene. We have a well-known pathway. It's what I'd call low-hanging fruit. The fact that it's progressive is bad, but at the same time, it allows us to target something that we might interrupt. And my little peach picker is here today and loving that picture. Mouse models from Valerie, her colleague Michaud, and then from my colleague Mark Lindsay. And fish that we will hear about from Bert himself. Okay, and that's coming. Stay tuned. I have to thank my providers. This is my team. It's huge. So we cover everything from pediatrics all the way out into adulthood. It takes a lot. And I'm mentioning this because somebody actually submitted a question saying, we'd like to start one in my state. And I'm saying, good for you. And the thing is, many centers have genetics, cardiovascular genetics, but you need to really have somebody willing to take it on. And it just takes a lot of energy. So I think of my role as like, this is the Gloucester fisherman from our New England, just helping you steering that ship. What about predictions? Don't we wish we had them? And I certainly don't. We're inching forward in knowing things, but we don't have enough. And again, these are the two papers that Bert and I wrote, that word emerging. I didn't plagiarize it. It's the only word that we could think of that sort of convey this idea. These are happening. And so natural history is how doctors think. We think about you as you change over time, okay? And that's where we're headed. Natural history, knowing about it can be scary, right? It can be scary, it can be sad. And so what we have is boundless hope. I smile. This is who I am because I have great hope, and I think we're on our way. I'm going to do my acknowledgements now. Hope I'm doing okay with time. All right, good, good. Okay, so the foundation, the board of directors, the referring physicians, doctors who just refer me patients, I owe them gratitude. I hope this is the up-to-date picture of the board. And then our medical advisory board, believe it or not, for those of you out there, it is global. And mainly because geneticists are by nature, we're connected. We know all these people. And this is our wonderful board, and they are wonderful. We have meetings like generally now it's every 3 or 4 months, but we're very forthcoming. We really try to share. And my last slide is that I'm going to channel Justin. We're very similar. We are willing to talk about this kind of icky subject of raising funds, money. So the way I frame is, first of all, I express my gratitude to my givers, I call them. And then I think about, what do I do? What makes me comfortable giving? Give blood, goodwill, the Pan Mass Challenge. I buy Girl Scout cookies. I support my schools, and I support this green space. So that's why when I'm talking to somebody, and just let you know, we have a separate Myhre Syndrome clinic fund. It's sort of a different fund. It's independent of Myhre Syndrome Foundation. And I thank them abundantly and constantly. The turtleneck is a joke, which is, I said to my mother one Christmas, I said, Mom, I don't need like my 10th turtleneck, but maybe make a donation. She did. What some people have done very generously is they donate each month. And when you do the math, it's stunning, isn't it, Justin, that you can get up to, $1,000 easily. This is my friend Chris. We've been rowing for years. That's the Charles River behind us. We row, we talk. She said, I'd like to help you. I said, sure. And just as Justin said, you have to have that ick factor, that awkward moment where you say, Chris, would you mind? And she has supported me, thankfully. And these are the Wacky Lynn sisters, 5 of us. And last Christmas, we said, okay, let's forget the presents. We don't need another Christmas ornament. We'll each make a gift to our favorite nonprofit. And that's what we did. So thank you. And with that.
Thank you, Angela. We have time for questions, so I hope you have them at the ready. There are mics throughout, or I can pass you this one or a different one. Our friends are listening online as well, so just make sure you're on a mic so they can hear you. Just a little caveat, and I know all the doctors will make this, is that we can't talk very specifically about individual cases, but obviously they're very happy to talk about general themes about what they know. Obviously there's licensing issues and all those good things, which we'll touch on tomorrow also about in our small group sessions. So do we have some questions? And don't be shy. I know it's the first session. And if we don't, I'm going to have to start looking at people in the red shirts, our board members. Inez?
Oh, fantastic. And I don't know if this is happening or not. Is there currently any sort of papers that are in the works, not anything specific that you might know about?
What a good question. So the main project that we're working on, again, with Bert and Lois is going to help us, are these guidelines. It's going to take us easily a year, and that will be actually a publication. But the really good news is next year in 2025, we're going to devote an entire issue of the American Journal of Medical Genetics to Myhre syndrome. And I'm going to be the editor along with Nicola. Yeah, it's great. And with Valerie. So for example, there might be an article coming out from MGHPT, further discussion about the physical therapy aspects of it. Do you see what I'm saying? So each of those things, I don't know what you've got going, Eva. Do you want to mention anything that's happening in Ghent? Could you say that again? Oh, methylome signature. He'll tell you about that, but that's very exciting.
I don't know why Bert's hiding right now.
Yeah.
He's working.
So, research comes in different ways. It comes as clinical, what I do as a doctor, in the clinic. Bert travels both ways. He does both the clinic, the bench, the fish lab, as well as the clinic too. Yes, sir. Yes, hi.
There we go. Okay. My question is basically, you mentioned at the end your hope and just kind of your overall as a physician, looking at the patients that you work with, what is it that motivates you and gives you the feeling of hope, and I know that's a very large question, but you can answer it how you want.
Thank you for that question. First of all, the reason doctors like us get into it is it's like somebody is fishing, we took the bait. It's passion. I would say I fall in love with the syndrome. I'm in love with this. I'm in love with my patients. We're not supposed to talk about love in medicine, but it's how I feel. But what I can see is even the little baby steps that we take just by talking to somebody, trying to explain what it is not, that helps. Knowledge is power, that helps too. The fact that we have a broader community, this helps a lot too. And then the notion of research, for me, the work that I did was just to give people what I call a denominator. If your child is this, what is your denominator? So again, that's knowledge. But I think there is real hope for the therapies. One type of therapy is that you see a process, progressive airway, progressive skin, progressive joints, and you try to think of a way to interrupt it. Again, I don't want to steal the thunder from some of the other talks, but that's it is too. And there really are sort of glorious genetic therapies that you may have heard. I get a kick out of the patient that I met where after the first visit, we just had an hour together, and the mother turned to me and said, "Are you going to do CRISPR?" And I thought, this is great. You guys are so savvy. You're reading the New York Times, the Wall Street Journal, you know about CRISPR. And CRISPR isn't something that you can order up. The disorders that have used CRISPR, like sickle cell anemia, the blood diseases, they are generally disorders of a particular organ, bone marrow, eye has been another one. Myhre syndrome is all over the place, isn't it? So we can't create a single CRISPRized gene, but there is something called editing, gene editing. Again, I'm going to stop because Bert's going to deal with that. Yes, sir.
Hello, Joe Alexander from Minnesota. Our geneticist was Dr. Yadley out of across Wisconsin, who said if I ever got a chance to meet you to say hello. So I
send
it
back.
That.
Yeah, we go back.
Retired now.
Okay.
So. But my question is regarding losartan as a treatment, and what your experience with that was. She actually had given us that article as a trial, and I just wondered if you had any successful treatments with that, side effects, and just your general take on that.
So losartan fits the bill as being part of that slide where I said low-hanging fruit. It's in this pathway. It makes sense. It's been used for years in adults with high blood pressure. In our group, we would say it's really our first choice for high blood pressure. That's what we use. The broader use about joints and contractures, I think it definitely is worth a study. Bert may have more experience with it. I don't prescribe it for joints. If somebody is using it for high blood pressure, we haven't yet started tracking it to see if it's changing the joints. I know anecdotally, because I know about anecdotes, people have said, oh, it made a big impact. But I do know that there is coming in Europe. I won't give you the details. Somebody's going to be trying to study it, and that's what should be done.
Hi, over here. Hello.
Hi,
Dr. Lynn. I feel like I'm seeing a massive celebrity, so it's a little starstruck. Question for you. I live in Canada. We have a pretty incredible healthcare system. When does someone make the decision that Boston is the place they should go to do be followed? Like, how do you decide that a patient's coming to you? How do they become a patient of yours?
Oh,
How does someone become like a patient of Mass versus like anywhere else in the world?
Yeah.
Why would somebody decide to come to you or make that decision, or do you make that decision?
no. Partly it's based on personal need, personal perspective. If somebody says, man, I have fantastic care where I am, that's great. Kate knows I do a lot of outreach. Doctors are not allowed to practice medicine outside of the state, and I'm only licensed in Massachusetts, but I get a call from Colorado, Utah, where I have all my buddies, because genetics is a small world. We know everybody everywhere. I know doctors in Toronto, and they'll call me, I'll talk to them. And then I'll say, and you can relay this education to your patients. So the way I get around this is I'm saying I'm educating people, I'm helping them understand what we do, and then they can relay it to their patients. I generally not say, you need to go do this. A few things are actually in our guidelines. So we do feel that everybody has to have an echo, right? And that's in the guidelines in our paper and also in gene reviews. So that's sort of easy. And then in terms of coming, expense is a big thing. It is not easy. I wish I had a fund. I wish like you had a fund. I wish we had this fund of millions of dollars that could pay for everybody, get on a plane, stay in a hotel, do everything for free. And we just don't. And the best that we can do is try to make your visit as nice as possible. And then what I try to do is my model is that we become your Myhre Syndrome medical home. And then you have your home wherever you are. Some people have really perfect homes elsewhere. They've got everything lined up. I know their doctors, we talk back and forth. Sometimes people are floundering. They really don't have those resources. But I do think that you're in Toronto, is that right? I mean, amazing town, as is Montreal, as is Quebec. So there's a lot of good resources. Also Vancouver out west. Hope that answers it. How are we doing for time?
We're fine. We can take another question if
Okay.
anybody has any more, or we can, yes.
Yeah, thank you for, I use that kind of clever description, low hanging fruit, because I wanted to show the peach tree really. But also because in genetics, we don't just think of isolated genes, bing, 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 bing. We think of pathways, a chain of dominoes. And TGF-beta signaling, where SMAD4 belongs, is very well known. My colleague, Dr. Lindsay, is really an expert in that, as is Bert. So people, as is Lois, and you're going to hear more. Does that help? So it's this pathway, the dominoes. And so it fits in there. And so the way therapy works is you might want to change that gene, or you might want to change something that is above it, feeding into it. So there are all sorts of approaches. Does that work? Okay.
Yeah, please go ahead.
Hi, I'm just wondering how we had tried to get genetic testing for our daughter since she was about 4 or 5 years old, and over the years, and finally she was diagnosed at 18. But over the years, we'd ask doctors, like, what do you think? There's something going on, and I'm just wondering how to get the information to your general provider that put this on their radar so that they can say, okay, yeah, we have this, and maybe we can test further.
So Maggie will tell you that we have a little information package out there. It's not just marketing for MGH. We have a couple of handouts. Tell her about one of the handouts that we designed. And this handout was created with a PCP, primary care doctor, who's on the board. But I think it's a lot of it is, and again, echoing Justin, you got to just, I always say, teach it, then preach it. You know, you got to be out there sharing it with people. And that would be you yourself personally, making sure your doctor is informed, and then the ripple effect. I can tell you that all the major geneticists in the United States pretty much know about it because of me. So I go to a meeting every year. It's called the Smith meeting. Your doctors, I think I know who they are in Utah or Colorado. They're there. They know Angela's going to get up and talk about something else about Myhre syndrome. This year I'm going to do musculoskeletal. And so that's one way. Again, it's this ripple effect. The primary care doctors might be a little more challenging. But the good news is if a child is different, the threshold for doing testing is getting lower. You don't have to reach this incredibly high bar. If you have a child with short stature, autism, intellectual disability, some of these things, most doctors will say, send them to genetics. We need to do a panel or an exome. You may have heard those words, a panel of genes or an exome, which is about 3%. And I hope things get better. I realize how you must feel about that.
And just at the foundation to build on that, we're doing things like thinking about how we do outreach to OT, to speech, to audiologists, to ensure that they are learning and understanding that to think genetic. And if they see other patients come into their clinic, because we will find you most of the time once you've had your diagnosis, and we want more people to find us and they don't know and they don't have access. So we're thinking about that framework and hierarchy and structure of where people might first have a touch point. And the autism world is a big one for that as well. And there's lots and lots of good work going on with autism and genetics right now as well. So work to do, but we're trying to make sure that as many people know about genetic testing as possible. Any more questions for Angela?
So my turn. Can we all please thank Kate?
Don't start me crying again.
You did a great job. And of course, Justin and Kathy too, but Kate has just been the engine behind this wonderful machine.
Thank you. Thank you. Thank you. Thank you so much, Angela. Angela is here all weekend. So I know she's going to be busy. I know you can catch her in coffee breaks and things like that, and she'll be around tonight. And we've got obviously tomorrow's sessions as well, which we're really looking forward to. But on to our next speaker. Lois is a highly valued member of our professional advisory board. She's a clinical geneticist and associate professor of pediatrics at Children's Nebraska, University of Nebraska Medical Center. She serves as the program director for the Medical Genetics Fellowship and is the medical director for the Myhre Institute for Genetics and Rehabilitation. Lois is passionate about rare disorders and is involved with educating medical students, residents, and learners from a variety of programs. Let's welcome her.
Thank you, Kate. Oh, it's so incredible to be here. It's so great to see all these families and everyone together. It's just really amazing. It is, isn't it? And following Dr. Lynn is really an honor as well. I know that as a clinical geneticist, I know there's only a few clinical geneticists here. For folks out of that world, it's probably hard to get a grasp on what does this look like with other conditions. And I've never seen this before. This is very special, and we can really credit Dr. Lynn for taking the leadership on that. Having a physician champion for a condition is rare in itself. I know it's hard to believe, but we just don't see this. And to see it all come together, and then Justin and Michelle and Kate and Kathy and Inez and all of the folks bringing this together and coming this far in this short of an amount of time is truly incredible. So I'm very grateful to you, Angela, for being an amazing mentor. And this is just really special to be here. So thank you so much. I'm going to back things up a little bit. So for those of you where Angela does, I think, an excellent job of breaking things down and making them easy to understand, we're going to back up even a little more. So for some of you, this is going to seem fairly elementary. However, I think it's also important to back things up for when you need to explain it to teachers or other care providers, things like that. So we're going to back things way up and talk about the basics a little bit more and go through the genetics, of course, and I'm very available. I think questions that you have are the most important because there's probably, 5 other folks that have the same question. And so I'd be happy to try to answer those as best I can. And yes, coming to you from Omaha, Nebraska, where I don't get to see as many individuals with Myhre syndrome, but I will mention that I'm licensed in Nebraska, Illinois, Kansas, Wyoming and South Dakota and Iowa. Woo, yes. And this is new. This just happened for me within the last 6 months. And so that means that if you live in one of those states or meet someone in one of those states, I could also see them by telehealth. But I do want to be really clear that the best care and most comprehensive care would be to go see Mark and Angela in Boston. But if you're in one of those states, I would love to help as well. Okay, so just to go back to where I'm sure most in this room know, but back in 1981, Dr. Myhre, who's actually a pathologist, recorded 2 male patients in Washington that had similar features. And then as the tradition goes, when the first physician or someone reports patients with a condition, then thereafter many folks provide the eponym of that physician's last name. And so that's where Myhre came from. And I know some of you in here may prefer to actually say that word in a different way, but we say Myhre. So then it progressed from there, as Angela already talked about, the laryngotracheal stenosis, arthropathy, prognathism, and short stature, or LAPS, was an acronym of a condition that was then realized by Lainey Lindor that we're talking about the same thing here, everybody. This is along the same spectrum of conditions. And so then, fortunately, in 2011, because it was in 2012 when I walked by an ICU room of a patient I thought I was consulted to see, but I was consulted to see her neighbor. And I said, well, but what about her? What's going on with her? That was just after 2 groups, the Legoff group and also the Caputo group, discovered the link to the gene. And this was around the time frame of when, as Dr. Lynn was already, I'm going to be saying that a lot. Maybe I should just have a little signal of, as Dr. Lynn alluded to earlier. But as she spoke about earlier, exome sequencing. So it was only available on a research basis then. Way back when I was training, you had to think of the condition essentially to be able to test for it. And now we're incredibly spoiled. When I'm consulted to see a patient, I can have a general idea or a certain group of conditions, but with these multiplex sequencing platforms, we're just very spoiled these days. Most of our work is on the back end. We can order an exome, or just even by phone last night, I ordered a genome on one of my patients. And we'll talk a little bit more about the differences there. But even if I thought, I wonder if this individual has Myhre or some other condition, because I'm a general clinical geneticist, though Myhre is certainly my passion and I love this condition. There's many other genetic conditions that I see much more frequently because they are not as rare. And so it's kind of an easy button. In fact, I'll even say that to my genetic counselor that's working with me that day. Let's push the easy button. Easy on the front end, more difficult but very gratifying on the back end, because we are so often finding answers for families. So with these new platforms, diagnosis is increasing like crazy. And I'm one in the camp. Angela and I have had discussions about this before, but I think there's thousands of people in the world with Myhre syndrome right now. I think that it is probably still less than half that know. And I think that this is going to be a perfect segue for my next slide. That genotype, or what is your genetic, Kristen? Yeah, isn't she cute? Yeah. So genotype is what helps us understand the phenotype. So a genotype, by the way, we all have them. As you know, everyone in this room has a genetic diagnosis. You might not know what it is, but none of us have normal genetics. We do know the genetic finding for several of you in this room, which, so I have goosebumps with everyone together. But it's that genotype, or knowing something about your genetic code, that can help us care for you medically. It's not about the label. We could all be labeled with something. But having that diagnosis brings us together to phenotype. So we want to use that genotype for what not to miss. So when I'm teaching the medical students, well, they seem fine, or they don't seem concerned to find their genetic diagnosis. That's okay. And it should be everybody's choice. In fact, in years to come, we might almost, for people who don't want to have genetic testing, instead of fighting for it with the insurers, I worry someday we might have to fight against being told you have to do genetic testing before we'll do this medical treatment, things like that, for folks who maybe don't want that. But we use that genotype to help us with what not to miss. And so that's why a diagnosis is so important. And of course, there are thousands of genetic conditions, but Myhre in particular is a great example of one that if we know about that on the front end, hopefully there are things we can do to make your life and medical care in a more positive direction, a better trajectory, because you knew maybe don't do that exploratory surgery, or maybe be really careful when you're doing those catheterizations and intubations, things like that. Again, sometimes you have to do it, but it's good to be, of course, as careful as possible. So genetics, what an intriguing topic. I just think it's the most amazing thing in the world, and I absolutely love my job. But it can be complicated. And I'm just going to break down a little bit what we're even talking about when we're talking about molecular testing, things like that. So every cell in your body, well, not every cell, red blood cells, others, etc., but most cells in your body do have a nucleus that contain your chromosomes. And so your chromosomes are what makes up all of your genetic material that makes you who you are. So this is back to, so my training is in pediatrics, and I did a fellowship in clinical genetics, but I'm also a lab geek. So I did another fellowship in clinical cytogenomics. And I would look at slides like this all day long. So we would look for chromosomes under the microscope. There's quite a process to get us to this stage, but it still kind of looks like a hot mess, doesn't it? So your chromosomes are ordered 1 to 22, and then many of us in here have XX, and many of us in here have an X and a Y, and they're ordered by numbers. So number 1 is the biggest chromosome, all the way down to 22, except actually, fun fact, 22 is not the smallest by genetic bulk. It's actually 21, but in the 60s, I think they couldn't quite tell they were going on a parent size and got those backwards. So most of you, or many of you in here that are younger than me, don't even know what these are. But these are, you could probably find them in a museum or maybe your grandma's attic. But we, especially those of us that were pretty geeky in this room, loved these. They were amazing. So these are the encyclopedias that go by alphabet, so A to Z. So if you wanted to pick, I did a report on manatees when I was in elementary. You go grab the M and you get in there. Well, your chromosomes are a little bit like this. I apologize for Bert and others for like, come on, Lois. They're not, but they are a little bit. Bear with me. So from chromosome 1 to chromosome 22, they are separated a bit. Yes, they do communicate with each other, and you can find information that pertains to each chromosome where they need each other to kind of work appropriately. However, they are also separate in a way, but a full set, you've got to have that full set, or you can get into trouble. Can you miss a word? Can you miss a paragraph even, or even a chapter and survive? Sure you can. But if it's a really critical word or a really critical chapter, there can be significant challenges there. And indeed, as in Myhre, it can be as simple as a single letter change. So this group of chromosomes, this is when a laboratorian takes it from that mess we saw before and then ranks them out, though AI is very helpful with that at this point. I'm a little jealous. But I will say, even when I was in training, before I'd ever even heard of Myhre syndrome, my favorite chromosome was chromosome 18, which is the chromosome that SMAD4 is on. It is on the long arm of 18. And you may wonder why 18. Well, if you see 18 there, when I was in training, we always called that the gummy bear chromosome. And who doesn't like gummy bears? It looks a little bit like a gummy bear coming at you. But right under that dark band is where the centromere, the waistband, sits. And then SMAD4 is located on the long arm or on the bottom arm of 18q. So that's where the SMAD4 gene is located. And for those of you who have Myhre syndrome, just one of your SMAD4 genes has a change at that point, and there's no way you could ever see that on a karyotype or chromosome testing. So this is also to encourage you, if you know someone, especially if they are over the age of even just 12, 13, 14, and they haven't been diagnosed. Oh, I had genetic testing. You know what? They were not doing this genetic testing. And so if they don't want that, totally okay. But if they do, what they probably had was maybe even something, I mean, for us in genetics now, this just seems so flip phone. This is a long time ago. And or even car phone. This is a long time ago. If all they had was a karyotype, or they say, oh, they already looked at chromosomes. They looked at the chromosomes, which is very cool, but they did not do the spell check. They did not do anything on a molecular basis to be able to find Myhre syndrome. So what we have to do for that is something called sequencing. There's several different ways that you can do this. If you see an amazing physician who meets the individual who has Myhre syndrome and says, gosh, you know, you check a lot of these boxes, sure, they could just send targeted sequencing. They could even send targeted to just the codons that we're interested in, which is what we had to do for that individual I walked by in the ICU. I wanted to personally deliver her sample to Paris, but I didn't get to do that. But we did get to send it over, and we said we want to look exactly here because she matches what the articles that they had just written about. And sure enough, it came up that way. But these days, I just have to push that easy button for these big sequencing studies because there's a lot of phenotype overlap with other conditions. So the sequencing that folks could have done is targeted, which many of you I know in here have, because we knew exactly what we were looking for. It could have been on a next generation panel, as Angela was talking about. Sometimes there could be panels. We have gotten SMAD4 on most of the panels for short stature, for hearing loss and other things, but it has to be there for them to look for it. And then these days, if you have solid access to care and insurance and all those other things are taken care of, we can do those big sequencing studies for exome or genome. So this is that adorable little girl that I first met. And so we found exactly what we wanted to test for. And it was just that little spelling change, which would be fairly, I think, fair to compare one word in that group of encyclopedias is about what we're looking for when we're looking for Myhre syndrome, which is located on so far just 2 codon positions. And so the exome and genome sequencing, this is something where, though it's difficult for primary care doctors to order it because of logistics and appropriate consent, this is a big test. So I, at this point, think that that's fair. I'm one of those advocates that physicians should be able to explain at least the expected results back from any study that they order, or we start to get into trouble sometimes with how things get explained once those results come back. But that's going to change over these next several years as there's more general knowledge about those sorts of things that can get you into trouble. But an exome, I'm sure many of you in here were diagnosed by exome studies. This is a big study that's looking mostly at the exons, or what we think are the expressed genes that are contained within a person's genetic material. So there's approximately 20,000 genes that each one of us has. And is this looking at everything? Not at all. In fact, that's where a lot of the clinical comes into play. If you tried to do, say, a direct to consumer, oh, they're looking at my exome, or you were told, I was in this research study, I thought it could be Myhre, but they said they did an exome, but didn't report that. First, they would have to have permission to report that to you. Second, they'd have to still be looking for it. So when we see consults in the hospital, we will put together, I have fantastic genetic counselors I work with that help me with this. We put together everyone's clinical phenotype, or that long list of every medical issue that they have. And then the lab knows to look for basically every gene that could contribute to that array of conditions. So I love what Kate said about we need to talk to the OTs and the speech pathologists and the audiologists and all these, because we need that information to be able to do the right genetic test to get those answers. So mutations in SMAD4 are found to be causative for Myhre syndrome. They've been noted at 2 different positions. Thank you, Angela. I hijacked this slide from you. At 496 and 500. So most have changes at the position 500. They're certainly closer together than this relatively on this map here. They're almost on top of each other. They're just 4 base pairs apart. But I think a lot of folks have asked me questions about, I thought there was just 1 mutation, or I thought, that there were, but there are 2 mutations, and it's confusing. So we'll just spell this out a little bit more in detail here. So the SMAD4 gene has a few domains. It's in the MH2 domain, where there are these codon positions 496 and 500, but indeed it goes, I'm not sure what the last position is on SMAD4, but starts at 1 and keeps going. So they're right next to each other. They are next door neighbors. They really are. And so at 496, we know about the arginine to the cysteine change. But then at 500, the reason that there are more mutations is because even though they're at the same position, they're changing the isoleucine to a different amino acid. So some of you in here have one of any of these different changes. And so that's why a geneticist would say, well, there are several mutations because there are several variant changes, but there's really just at these 2 codon positions. So there are a family of SMADs. So SMAD4, this is the gene, of course, that's implicated in Myhre syndrome. By the way, a gene, whenever you see something all caps italicized, that's when we're talking about a gene. So there's a number of genes, and when they're all caps italicized, that's the gene. If it's all caps non-italicized, that's when we're talking about the protein when you're reading the literature. But the gene provides instructions for making that protein, and it is involved in transmitting chemical signals from the cell surface to the nucleus, SMAD4. So SMAD4 we think of in a critical signaling. It's moving those messages around. This is a gain of function mutation, and I know that the term gain of function got a lot of press a few years ago. This is really, it's different than thinking about gain of function in a research sense, though of course there are some correlates in that it's where instead of dropping out a function, it is more inserting an extra function that is causing something to have a change rather than just missing. It's not that the SMAD4 protein is missing or that even part of it is missing. It is that it has an added function functioning differently. So that SMAD4 protein is part of the signaling pathway in the very popular TGF-beta pathway that you've been hearing a lot about, which is critical in many different connective tissue disorders. In fact, we had an abstract from a few years ago where we compared Myhre syndrome to Marfan syndrome, where instead of being tall and long and more on the kind of more dislocating side of things, this connective tissue disorder, as you know all too well, makes things more short and compact and tighter, and joints not at all apt to dislocate, but almost get stuck before they can fully extend. So kind of the opposite end of the spectrum, both are in that same pathway. The other SMAD4 conditions, so it was just in June that I saw one of my patients, Kaylee, who's here with her friend Dougie. Isn't he cute? So Kaylee has the juvenile polyposis syndrome. So if you send a care provider or someone who wants to learn more about Myhre and they say, oh, you know what, I Googled that, you're a little off there. SMAD4 causes juvenile polyposis syndrome, not Myhre syndrome. Well, that's because we've known about JPS for a very long time. But that is from a loss of function at SMAD4. So juvenile polyposis syndrome is what Kaylee has here. Say, gosh, she just looks great. If you look closely, she's fairly what we call in medicine dusky. She has a lot of arterial vascular malformations, which is what the loss of function can cause in this hemorrhagic telangiectasia disorder, where her lungs are sadly almost full of these changes that don't allow her to utilize her oxygen appropriately. So she is truly cyanotic. She has a dusky blue color to her. So it's a lung issue, but it's different. You know, it's different. And not all have the AVMs, or they can be anywhere. They can be in their brain or other organs as well. What's the polyposis? Well, it's in the colon. So their colon can be full. This is a CT of the lungs, as I know many of you know, you've had to see those, but this is a colon that can be full of polyps. And so Kaylee, she's getting to the age where she knows she's going to have a colectomy soon, where they will remove that. But this is sort of the sister condition. And she actually emailed me this photo. She was really excited to share it with you and kind of teach you about the other SMAD4 conditions. So when people talk about JPS, this is the other SMAD4 condition. Also, in my mind, at least, some people might argue this with me, but it's in the TGF-beta pathway. They absolutely also have connective tissue disorder issues. She would be more prone to dislocate than to have tight joints. So kind of the opposite end, which is what you would expect for a loss of function change. So for the inheritance, it is autosomal dominant. And yes, you can say that even if you're not seeing it go through a family, as in with SMAD4. Autosomal dominant simply means that it only takes one of those two copies on chromosome 18 to actually cause the problem. You've probably heard de novo, or that this was found to be de novo if they did a study where they also got samples from mom and dad. That means that it's new in the individual being tested. We cannot be certain it's de novo unless mom and dad were tested, but we can make a fair assumption if the child tends to have a very unique condition. They were found to have the SMAD4 mutation. Mom and dad were not tested, but they clearly do not have the condition. So for those of you who maybe are in that boat, that's completely fine. Odds are that if they did a test of a cheek swab or a blood sample, especially, that you would not have that change. And so it's fair to assume it's de novo, but those of us in genetics are kind of sticklers on that. We try to only say de novo if you prove that it did not come from a parent. We do have some familial cases of Myhre syndrome where we know that there's an individual parent who has had a child with Myhre syndrome. So that has been seen and reported within this past few years here. And just like the number of diagnoses, I think there's probably many families throughout time who have had Myhre syndrome. We just don't know about them. And especially if they have more mild features, we would expect that. All of us humans are different creatures, aren't we? There are likely many families who even have multi-generations of Myhre. Those haven't been well established yet in the literature, but I'm certain that they exist. And of course, the more mild their features, the more apt this is to be the case in undiagnosed. So some frequently asked questions that I've had over the years that I thought we could run through today. Yes, we do think that Myhre syndrome is a diagnosis that requires a pathogenic change in SMAD4. And there's many reasons for this. It's clear that the vast majority of folks that present with this connection of symptoms do have this change. But it's more than that, in that, because I know, and even in the literature, there are people who were even reported to have Myhre syndrome, but did not actually have a pathogenic change in SMAD4. I would say my biggest concern as a physician is that we're missing something else for those individuals. And I don't want their journey to stop with thinking, I have Myhre, I know my testing was negative, but that is where I have connected. There's a lot of overlapping symptoms. And what if it is something else where if we found that correct diagnosis for them, that it would help them more on their medical trajectory to know what that correct diagnosis is. So we do think that it requires that. Now, sometimes there are limits to access to care, and where if for some reason we weren't able to get the genetic testing, can a clinical diagnosis of Myhre syndrome be made without genetic testing? Sure, I think so. And I think at some level, you can also say that what we want to do is prevent any harm. And so maybe it's best to make sure, because we don't want to miss anything, that if we could not for some reason get genetic testing done, that we use it, as we say in medicine, as a working diagnosis. And that is done at times. And with Myhre, there are several different characteristics that could make us feel like we're pretty close to that. Let's see. We have not yet learned of anyone with Myhre with appropriate genetic testing without the pathogenic variant. And so yes, again, just remember that we don't want to miss what an individual might have. Variants at position 496, they can trend to have some milder features. Of course, there are people with more severe end and mild end with both codon positions, but that is where we have seen that trend. Again, if a genetics workup was done years ago, it probably didn't include testing for Myhre syndrome. So encourage those folks to update their testing if they would like to. It is typically caused by a germline variant where all of the cells in the body have it. You've probably heard about mosaicism in different contexts, and we haven't found that to be a significant presentation for Myhre. When you're Googling, when you're looking for things with SMAD4, just as with JPS, also be careful because there are somatic variants in SMAD4 that can lead to different kinds of pancreatic cancer or other types of cancer. Yes, we have established that neoplasia can be at increased risk in Myhre syndrome, but most of those non-germline changes or at other codon positions are going to be talking about entirely different conditions. We do think that Myhre syndrome, advanced paternal age could contribute, but it's impossible at this time to know what necessarily caused the variant to occur. So there are point mutations in genes that we know that sperm are more likely to be able to carry than an egg or an oocyte. But really, which chromosome they occur on doesn't change anything for medical care. So for the medical care of Myhre, knowing whether this came from the paternal or the maternal chromosome isn't necessarily helpful for us in taking care of patients. There are, let's see, we do not yet have a report where the buccal or the sample was negative, but a different tissue type was positive. So I've had this question before where the testing was negative by cheek swab or a blood sample. Should we go biopsying things? I don't think so. We will be proven wrong potentially at some point, but you don't want to cause harm. That is definitely not the case. And biopsies, especially with Myhre syndrome, can be unfortunately more invasive and cause issues. I think that about covers it. I would mention that dual diagnoses are possible. I've been humbled, especially over these past few years, where we're doing these big sequencing studies where we will find that an individual has maybe a deletion of, 3q21 deletion plus another condition like Myhre. Us humans, we have a lot of genetic changes, and it's very possible. So if you have Myhre syndrome or a loved one with that, and you think, I think that there's even more going on, is that possible? It is possible. And so it's certainly something to consider, and sometimes looking further could be helpful for medical care. So I know my time's about up, so I will wrap it up, but welcome questions now or anytime during the conference. Thank you, guys.
Yeah, thank you. Thank you, Lois. So we do have some time for some questions before we're having a break. We're going to let you have some tea and coffee very soon. Oh, we've got two. Okay. Should we go? I'll start here because it's Janira, and then I'll run over there.
Thank you. I'm just curious, how recently would, can you hear me? Sorry.
For Zoom folks at home.
How recently would you recommend someone having genetic retesting done?
Yeah, if they have easy is if it was before around 2010, absolutely, because they didn't even know. So even if they had SMAD4 sequencing, I know this is weird to think about, but they actually probably wouldn't have reported this because they have to know the abnormality to be able to locate it. And as a lab person, you can't just report random changes. You have to know what you're reporting. So easy before 2010. And I would say it was unusual to be able to get exome sequencing before 2019. And so if they haven't had it within the past 5 years, and even then, I know Angela and we can just really be astonished. And this is just because it's our specialty, but sometimes to test for single spelling changes, like in the book, a spell check, all they did was check to see how many pages were there. It's never going to find the misspelling. So it really depends on which study they had too.
All right, give it over here.
I have a question about presentation and genealogy, or I guess you could say, if someone were with Myhre or maybe with another genetic condition, if they present very mildly and were to pass that on to their child, is their child any more or less likely to have a mild presentation, or is it just a light switch on off, and then what their bucket of like symptoms would be is what happens when their body is created?
Yeah, excellent question. So we have a term for that as well. It's called variable expression. And with Myhre, I would say we've seen a trend that for the few familial cases that have been reported, that they've been more on the mild side. And so they would probably stay on that side of the spectrum. However, we are always trained to counsel. It could really, it could be quite severe to very mild, really, no matter what, depending on your other genetics, other environmental things that have happened. Especially with Myhre, if you had an issue where you had to have a laparotomy or something, you could end up with severe end because of the iatrogenic things that happened essentially. But it could be that as we see more families, I think we'll continue to see that families tend to have a similar course, but will depend on what the world throws at them.
Thanks so much for the talk. It was really fascinating. I'm curious to hear more about de novo mutations, because obviously they're not or it seems like the science is heading to a place where we are starting to understand that they're not entirely random. So like the science around advanced paternal age, for instance, and what
Yes.
this might mean for a lot of us who have families with de novo mutations. So for things like, and where it's confirmed de novo, for things like any additional risk for non-Myhre siblings, things along those lines.
Yes, absolutely. So while we think that, and you're right, there are some emerging studies that are coming out about that, like with other conditions where there are these point mutations, advanced paternal age may contribute to that. And that's more of what I think we're going to see coming out in the literature soon. My take at this time, I have to be very careful about that because, as Angela pointed out, our opinions may change over time. While I wouldn't necessarily be opposed to unaffected siblings being tested, I don't know that it's a good use of resources. I think it's very unlikely that apparently unaffected siblings with Myhre in particular probably also would have a mutation, but at a mosaic level, something like that. I don't think that dads need to be tested. If they had a cheek swab done, etc., we would expect that in an unaffected father or mother. We would expect that to be normal. What can be done is that it could be possible, and I'm not aware of a family like this that exists at this time. We would love to learn about them if anybody else knows about an unaffected parent dyad who did have more than one child, because that would be where we might expect maybe there was something probably more in the early development of sperm cells where it could be at a little bit of an increased risk to have a mutation at the same codon position. But I'm not aware of any families yet to date that have had that, which supports what I'm currently saying, which is that testing the siblings or parents or prenatal testing for siblings, I think would be of extremely low yield. Is it possible that a father who has had one child with Myhre could have another? It is possible, but right now we think that it is incredibly unlikely to happen. But it brings up a lot of questions, doesn't it? Oh, that's a little debated among several geneticists. I think most of us agree, it's different than us moms. You have a baby over 30, they put like geriatric on your chart, right? But for men, it's a little different than that. Sperm is constantly regenerated though, and so there can be an increased risk for point mutations in general. And so, Angela, I always say 50, 55, but I know it's been.
This is one of the most difficult topics for the
Yeah.
whole meeting. Because even though we feel really close to all of you, your experiences are so different. We wish we could be having individual counseling sessions with each person. Number one, this is really important research and it's emerging. It's being done by really probably the best center. It's in Oxford, England. And there's going to be a paper coming out in the fall. We do know that advanced paternal age is associated with many similar disorders with de novo mutation. So thanks to Liz for asking that question. We also know it applies to Myhre. There's not yet a cut where we'd say 40, 45. Oh, thank you. Thank you. 40 or 45. I would agree with exactly what Lois said. It's not 40, 45-ish, 50, but there's no number. When we work with women, we actually have a table where we look at it, we call it older age. But in terms of what we're discovering, no matter what the paper will say, it's not that it caused Myhre. Everything is still about risk. But we are trying to say that there is an association in general with these new mutations. Of course, you'll see the celebrities who get 75, whatever, Mick Jagger, right? People have had children at an older age, so it can happen. I agree with what Lois said, though. The chance of what we call gonadal mosaicism in the gonad, at either the egg or the testes, having a second sperm is extremely low. We usually use 1% as our lowest number, so it would be much less than that. But I appreciate the fact that people are willing to ask this. The question about whether the gene effect is more severe through the generations, you have to think about it this way. We do know of families, Bert does, I know of more, I know of things that are getting published in which there is a parent with at least one child or more than one. So the parent, Bert reported the first family, an important paper, Myhre et al., and it was a mother who had 2 children. The mother was severely affected, and the children also had a severe form. We know of other families where there are generations of people, 3 generations, I think Bert knows, where there was some impact, but they were functional. And then I'm going to be seeing a patient in the fall where the mother by picture looks completely typical, but I don't know, and I hesitate to say more. So it does happen. So by definition, you would not have the most severely impacted person, either from lifestyle or physical, getting having a pregnancy. It's going to usually be in the other direction. Does that make sense? Okay. And I say this with respect to everybody in the audience. I hope none of it comes across in the wrong way.
Any more questions before you get your, oh, there we go. I'll pass this over.
Thank you. You mentioned in position 496, there tended to be more mild conditions, and so forth. Is there kind of a charting of, similar to Dr. Lynn's, as far as, okay, 65% presented in here, or 55% that would say, oh, in 496, you're more likely to have X, Y, or Z condition, and then how that advances over age?
Yeah, so I think the natural history studies, like they're recent, and that is great. How did you get those slicks from AGMG? Nice work. That is excellent. So, yeah. So looking at those trends right now we're going to be putting that together more efficiently. What I will tell you is that just overall in looking, height in particular, we tend to see the more severe short stature with the position 500. But almost everything else, maybe the fibroproliferative response versus just general nature, seems to be a little bit more significant in 500, but we have to be really careful with that because there's what's more mild for 500, the more severe of 496 could certainly overlap, but just in general at this time, and that is not at all to say that some individuals with position 496 have had really significant challenges and severe issues, but generalities, I would say height and the fibrotic response may be less so severe, with a big may in front of that, depending on the individual, but that tends to be the case.
So I'm going to start and then I'll ask Bert to help out. The thing we know for sure is that 496 is the one that is less likely to be associated with small size, but definitely can be. So if I get a call from somebody and they said, I'm following a child with Myhre syndrome, height is completely normal, it's more likely to be the arginine variant. In terms of some of the other variants, we did not see great differences. It's in my paper. Bert, can you give a shout out? Because your paper looked at that.
Oh, perfect.
Bert's gonna be doing a presentation, so he's gonna cover some of that when it comes to the adult paper that he did as well. But yeah, please pick up a copy of the report, have a flick through. Angela is here and can talk more about that. I think we will thank Lois very, very much. While we're doing that, I'll introduce our next speaker. Nina Thompson, PhD, is a pediatric neuropsychologist at the Children's Hospital of Philadelphia's Department of Child and Adolescent Psychiatry and Behavioral Sciences. That's a long business card.
We call it DCAPS.
There we go, DCAPS. And an associate professor of clinical psychiatry at the University of Pennsylvania. Nina specializes in the impact of central nervous system injury or impairment on neurobehavioral functioning. She has extensive clinical and research experience related to the cognitive impact of genetic and metabolic conditions, congenital heart disease, and sleep disordered breathing, and is here today to discuss the neuropsychological evaluation process. I got it all out. Please join me in welcoming Nina.
Hey, Sure. Thank you, everyone. And also, it's been a minute since I've done an in-person talk. So if I wander away from the mic, feel free to yell out at me to wander back. All right. So I'm going to talk about neuropsychological assessment services. I have kind of arranged my slides from very basic to kind of advanced topics. Can I just ask how many people are familiar generally with neuropsychological evaluation, have done one, know somebody who's done one? Okay, so I might go through pretty quickly these initial slides so that we have time. I'm always, willing to go back, and I'm also going to be here during the lunch hour. I do have to catch an Amtrak to DC this afternoon, but you're welcome to reach out to me afterwards if you have any, further questions. And I would recommend stopping by that educational psychology poster that's been mentioned, because I'm sure a lot of that will be relevant as well. So as Kate mentioned, my name is Nina Hatungari Thomas. I don't have any financial disclosures. The goals of this presentation, I want to talk about what is neuropsychology, who neuropsychologists are, what's involved in the evaluation process and how it might differ from other evaluations that might be mentioned to you, who would benefit from it and what the different parts of it are, and then some examples of how we approach different referring health issues, assessment methods, and recommendations based on what an individual patient needs. I will warn you that I am a pediatric neuropsychologist, so I will default to talking about kids. I know many of you are adults or families of adult patients, so please forgive me. I will just go back to kids because I see kids up to adolescence and early young adulthood. So what is neuropsychology? Neuropsychology is a subspecialty of psychology that studies the relationship between the brain and our daily behavior. So basically, we're using behavior to help understand how an individual's brain functions. So not the structure of the brain, but the function of the brain. It draws from lots of different cognitive sciences, including neurology, especially a big overlap with behavioral neurology, neuroanatomy, different parts of psychology, and typically employs clinical interview, tests, and guided observations as part of the different tools for evaluation. So there's a lot of different ways to assess brain and behavior functioning. First of all, anatomy. These are the scans other people have shown, MRI, MRA. They're showing the structure of the brain. There's physiology. Physiology refers to ways the brain is functioning. For example, electrically, chemically, physiologically, things like EEGs or PET scans, MEG. Those are different types of functional neurodiagnostic or brain imaging tests. And then we do a different type of functional assessment in which we provide, this is my kid actually, he's a lot older now, but we sit at a table typically with kids and put them through a bunch of different measures that are meant to assess different aspects of their thinking, behavior, and also get oftentimes ratings from parents about their behavioral, emotional, social, and adaptive functioning. So if you're a neuropsychologist, I'm going to skip through this because you probably don't care too much. But the main thing I do think I want to emphasize is that in the United States, at least, I'm not as familiar with international training, but neuropsychologists are psychologists. They're not medical doctors. So they have a typically PhD or PsyD. they do not have an MD, so they don't prescribe medication. They might say, you have attention concerns at the level where you might benefit from talking with your medical doctors about medication, but they don't prescribe. And they do special training during and after getting their doctoral degree to better understand these brain behavior relationships. Am I too close to the mic? Is it like, okay. You're doing an undergrad degree and then about 5 years of graduate study, a required 1-year internship, which is actually part of the doctoral degree. So it's really 6 years. A required in most places 2-year residency, specifically in clinical neuropsychology. And then there's optional board certification in clinical neuropsychology and even a subspecialty board for pediatric neuropsychology. So pediatric neuropsychologists, in addition to seeing kids, they are trained to evaluate, diagnose, and treat individuals at different phases of development. So they work with patients from infancy to young adulthood, and the goal is to understand typical brain development so that they can kind of keep in mind what you would expect a typical developmental course to be and how a particular medical condition can impact that course. So a neuropsychological evaluation, for those of you who've done this, and of course there's many different types of evaluations. Neuropsychologists are in multiple settings, in inpatient rehabilitation units, and in adult hospitals doing dementia evaluations. I'm going to talk about a typical comprehensive outpatient neuropsychological evaluation. But the goal, of course, is to understand how medical conditions, or sometimes the treatments for those conditions, can impact what we call central nervous system, which is the brain and spinal cord, and how that might impact a person's development. So the evaluation tries to understand and describe the way that health issues are impacting individuals cognitively, emotionally, and behaviorally. And behaviorally can include a host of things, including social and adaptive functioning. So when you do a comprehensive neuropsychological evaluation, your goal would be to address all these domains. Now, it's not always possible. Some individuals have not emerged into academic skills. For example, they might even be at the early academic skills, so like color naming, things like that. But in general, you're hoping to evaluate general cognitive abilities, reasoning and problem solving, memory, which includes multiple types of memory, so verbal and visual memory, and different aspects of memory, encoding, retention, recognition, retrieval, processing speed, language, receptive and expressive language skills, executive functions, mood, social, and personality, which is typically done through ratings rather than direct evaluation, adaptive functioning, and then one possible academic achievement, so reading, spelling, and math abilities. And I'll talk about that in a little more detail as well. So of course, the goals would be to clarify the problem, to either provide or sometimes confirm a diagnosis. Sometimes people have a suspicion of what their diagnosis might be, but maybe the school has just said, oh, you have learning difficulties, and you want to know, do I actually have a learning disability diagnosis or not? Sometimes things can be a little unclear. Oops. Oh, sure. Let me know if you need me to do anything on this end. While we're waiting, and anyone have any questions about anything I've covered so far? Okay. All right. So we're trying to clarify the problem, provide or confirm a diagnosis, identify the cognitive strengths and weaknesses, and make recommendations, sometimes for medical providers, often for home, school, and community functioning. So components of the evaluation typically involve a review of records, and those could be medical records, educational records, records from outside therapists, scans. I try to get it all. Interview with the patient and family, sometimes together, sometimes separately for a clinical interview with the older patients. behavioral observation. So throughout the evaluation day, we're looking at how individuals are interacting with us, their language, their motor skills, as well as their performance on the tasks. Testing, which if you've gone through this, can be pretty exhausting. Sometimes we do up to, 6 hours of different tasks, each focused on a different skill. Scoring and interpretation, and then preparation of a report and feedback. So I think part of it is, neuropsychological evaluations are obviously, I happen to think they're very helpful. They're comprehensive, useful, especially for individuals with rare medical conditions that people might not have a good understanding of. But a lot of times you're wondering, I got put on a wait list and they said I can't get a neuropsychological evaluation for a year, 18 months. What about this evaluation is going to be different from other evaluations I might have? How is it necessary, or is it just a bonus? So I think the biggest difference, and the ones most families are probably thinking about, is how does this differ from what would be called a psychoeducational evaluation, which is typically the kind of evaluation a school would do, in particular for determination as to whether a child needs special education services. So school assessments do generally include aspects of what would be done in a comprehensive neuropsychological evaluation. So general cognitive ability, or IQ, and academic testing. In fact, schools, definitely have the ability to do very comprehensive academic testing because that is their purview. School psychologists do not typically use performance measures of attention, learning, memory, or executive function. Some do and have a special interest and have maybe gone outside the typical training, but it's less common. And if things like attention, executive functions are assessed, it's typically through parent report or questionnaires or teacher questionnaires. School psychologists do not typically incorporate brain behavior relationships into their recommendations. It's just not what they do. It's not typically a large part of their training. And so I think that's not something that's typically fair to expect. So when you look at a school psychological evaluation, it could be IQ, academic achievement, and sometimes some adaptive, social, and emotional ratings. Compared to a neuropsychological evaluation, which has ideally all the domains I mentioned earlier. The goal of a neuropsychological evaluation is to be comprehensive, to be process focused, and to be focused on these brain behavior relationships. So who's going to benefit from a neuropsychological evaluation? Obviously, I think pretty much anyone would benefit from a better understanding of their cognitive strengths and weaknesses. I know as I've become a neuropsychologist, I realized, I have terrible visual memory. I never knew that about myself. I just knew the first test I ever failed in my life, like flat out failed, was look at this map of Europe and fill it out. I was so used to sitting in class. I'm like, okay, if I'm paying attention, I'm going to get 100 on the test. That's because a lot of information presented in school is verbal. When I get something visual to this day, I was in Europe about a month ago. I still could not do that. When I have to fill out a map of Europe, I say, Italy's the boot. Down the left-hand side, it goes France, Spain, Portugal. I put it into words. That's called verbal mediation. I'm shifting visual memory into the skill that I actually am good at. If I'm downtown in Philadelphia, I will stand on a street corner and say, Market, Chestnut, Sansom, Locust, Spruce, Pine, South. Okay, 7 blocks. My husband can just picture a map of Philly in his mind and navigate. That's like magic to me. So honestly, everybody has these things that they're good at, things that are a little harder for them. Depending on what you're good at and what's a little harder for you, it might be something you know about yourself, or it might not. Some of these difficulties are very specific, and people early in life get really good at navigating around them, compensating for them, coming up with strategies to make sure that they don't cause obstacles. But in your psychological evaluation, I always say is like looking at the road ahead, figuring out where the potholes might be, and then steering around them instead of driving straight into a pothole, breaking your axle, and that's when you get the evaluation. So in that way, I think it's very helpful. So in the United States, unfortunately, a lot about neuropsychological evaluation in a medical setting, like an academic medical center, children's hospital, is determined by health insurance. So neuropsychological evaluation is considered to be medically necessary when used for, the biggest part of this is that all these criteria include the presence of a medical condition. So good news, you know, if you have Myhre, you know that you have medical condition, that obstacle is already behind you. Otherwise, your insurance company might argue that it's only important when you have a new onset of cognitive concerns, when there's concerns about cognitive decline, when you're interested in something that's not assessed through school. So this is a big one. A neuropsychological evaluation that's determined to be a medical necessity can generally not considered to be for primarily educational purposes. So for school planning or for vocational assessment. Personally, I hope no health insurance representatives in the room here, but I try to sneak in as much academic testing as I can, you know, that I think is going to fly, and that's been fine. But everyone should know, if you're requesting any kind of special procedure that your doctors have told you will be helpful, and you get a denial from your insurance company, not a like, oh, we have someone that in network can provide that, but a flat out denial, you can appeal and ask for a peer-to-peer consultation. And I definitely do this. I will call whoever the insurance company has designated and talk about why I think this evaluation would be beneficial. All right. As I mentioned, not primarily for educational purposes if you are trying to get it paid for by your insurance company. Also not for people who have conditions that are not known to affect the brain. And if there's no changes, if you have sort of chronic health concerns that are generally unchanged, they might say you need a significant new change. All right, so Myhre syndrome, you know, you've gotten great overviews of all the different organ systems that might be impacted. Obviously, the brain differences for me are the most, you know, the first and foremost thing I would think about. But all these other conditions can have significant impacts on cognitive functioning. Cardiovascular issues alone, we see a lot of kids with congenital heart disease or vascular issues, sensory issues like hearing loss, breathing or respiratory issues, hormone, puberty. We see a lot of kids with endocrinological concerns. Sleep disturbance or disruption can have a significant impact on cognition. Social issues like autism spectrum disorder, gastrointestinal issues can determine the level of nutrition you're taking in and how your brain is developing. You know, you need a lot of fat to develop those white matter pathways. So you want to make sure that that is not impacted by restricted eating or malabsorption. And, you know, certainly we see kids with primarily kidney dysfunction as a concern for the impact that can have on cognitive ability. All right, so who might want to get another evaluation either instead or in addition to a neuropsychological evaluation? This is probably the biggest difference, and this may even be relatively specific to CHOP. But here we have a whole group of people who just do autism, new autism diagnosis, autism research, clinical autism evaluation. So when the primary question is, does my child have a diagnosis of autism, a new diagnosis of autism that hasn't already been diagnosed, we send them to that group, and it's a much quicker turnaround. If you're looking for purely an ADHD or learning disability diagnoses, ADHD is a behavioral condition. It's determined to be present or not based on impairment in multiple settings, which is usually home and school. So it actually can be diagnosed and is ideally diagnosed through parent and teacher questionnaires, in addition to potentially in-office tests. Learning disability, you know, a psychoeducational evaluation is basically designed for learning disability, although I will say it does get a little trickier in kids who are medically complex. If your primary concerns are mood or anxiety, that's typically not the focus of a neuropsychological evaluation. We might assess those things, but that would be a pediatric psychologist who deals with those conditions primarily, like cognitive behavioral therapy, for a specific phobia or something like that. And, you know, if there's a primarily psychiatric concern, delusions, hallucinations, things like that, that would be a medical doctor who specializes in mental health, so a psychiatrist who would do that evaluation. There are some people in psychiatry who call themselves appropriately neuropsychiatrists, and that gets a little confusing for people who are seeking a neuropsychiatric evaluation and get a neuropsychological evaluation or vice versa. So just a heads up about that. Also, if you have relatively isolated concerns, if you're just concerned about speech articulation or fine motor skills, pencil grip, you know, gross motor skills, balance, coordination, or a specific medical concern, restricted eating, compliance. My child doesn't want to wear a CPAP and they really need to. So that's an adherence issue. Again, there's individual providers who can provide direct evaluation and treatment for those concerns. And then the last, I do like to mention, if you're thinking of suing anyone, legal forensic concerns, that's a specific type of individual who you would want if you're expecting someone to come to court and be an expert witness for you. You would be seeking a forensic evaluation. All right. These are not obstacles to neuropsychological evaluation for the most part, but I think they're definitely things you want to be aware of and make your neuropsychological provider aware of as soon as possible to make sure you're getting with the right person and that they're appropriately ready to accommodate what your child's needs might be. So individuals who are deaf or hard of hearing, if you have, you know, hearing aids, bone anchored hearing aids, you can hear conversation in a quiet room, you're typically fine. If you're primarily fluent in sign as opposed to, you know, spoken language, we actually are fortunate enough at CHOP to have a neuropsychologist who is fluent in sign and specializes in evaluation of individuals who are deaf and hard of hearing. So cochlear implants and those types of things. So that's something you might want to let people know. Significant visual impairment, so not just astigmatism, glasses, but things that like a cortical visual impairment, visual field cut, blindness. You know, we do still evaluate individuals with those conditions, but we might have to enlarge materials, adapt the battery in some ways, or, you know, skip some tasks that wouldn't be valid. Significant motor impairment. This is typically more people who don't even have the ability to point or gesture. We do see a lot of kids who have fine motor problems, difficulties with pencil grip, use assistive technology. So that we're pretty used to, but it's good to know going in because those might require adaptations to the battery as well. Obviously, if you're in another country and your neuropsychologist is fluent in your language and it's not English, that is probably something they have worked out. But if you're in the United States or a primarily English-speaking country and you or your child's primary language fluency is not English, just be aware that most of the tasks are developed in a particular language and norms are collected for that particular language. Doesn't mean you can't be seen, but it's going to involve a lot of clinical interpretation. And what we may do is try to find you a provider who speaks your language or is bilingual in your language and has experience with alternative measures that might be normed in that language. So just a heads up. And also, you know, the last thing I do tell families, you know, just to manage expectations is a neuropsychological evaluation, if you're used to like getting an EEG or a blood test or even an X-ray, sometimes you might not recognize how much it's dependent on interaction with the child. But if a child or a person is not able to, you know, cooperate, if they're unwilling to cooperate, if they're just going to refuse, that's not something we can't. You know, we can use stickers and prizes and rewards and promises, but ultimately you cannot force somebody to do something that they don't want to do or are completely, you know, unable to bring their effort to bear on doing it. And in a lot of circumstances, I would rather not get data at all than to get information that says somebody's not able to do something that they are able to do. They're just, they don't want to do it. So I always tell families it's good to go in with what specific questions you want the neuropsychological evaluation to assist you in answering. So I always start out by saying, what brought you here? What questions are you hoping this evaluation will clarify for you? Sometimes it's as simple as, well, my doctor told me to come. Great. I'm glad that doctors are aware of us and telling people to come. But sometimes parents have, or kids, young adults have their own questions. Do I need accommodations for standardized testing for college entrance exams? Do I have a learning disability? I've always suspected that maybe I have this. Can you tell me for sure if this is an appropriate diagnosis? And if so, what do I need to do about it? So, of course, we've talked about the benefits being to determine the cause of a child's difficulties. And when I say the cause, I'm not saying this part of the brain, particularly this part of the chromosome. I'm saying, okay, the reason that they're having this difficulty is maybe not what you think it is. So a lot of families will come in and they'll say, my kid has a terrible memory. A lot of kids don't have a terrible memory. They have terrible attention. And if you're not paying attention, you're not going to remember something. It's not even getting through the door. Or they're paying attention, okay, but their language comprehension is impaired. So it's not that they're not remembering it, it's that they didn't understand it or process it to begin with. Or some people have really good encoding, the ability to get the information into memory. They hold on to it okay, but their retrieval of information is hit or miss. If you give that person multiple choice, they might get 10 out of 10 on multiple choice. But if you just ask them, tell me how many words from that list you remember, they might remember 2 or 3. The information is in there. It's just difficult to pull it out when needed. And there's a lot of really easy recommendations you can make for that, like only giving people recognition format testing. So multiple choice, true, false, fill in the blank with a word bank, matching. Those are all types of tests where the answer is there and the individual just has to recognize it, as opposed to fill in the blank without a word bank, essay, short answer. All those things require someone to retrieve information spontaneously, and that can be a big difference for some kids. All right, evaluation of strengths and weaknesses. I've talked a lot about that. Indications of a learning style and how they're processing information, recommendations for appropriate supports and interventions. So some of our job is providing recommendations directly, and some of it is saying, you need occupational therapy, you need speech therapy, you need other providers to get involved. And then finally, sometimes it's as simple as providing a diagnosis or documentation that families need in order to get the therapies and services that they already know they want. So, I often tell families, no one knows your child better than you do. But if you go to the school and say, my kid learns better this way, they might be like, sure, okay. If you go to the school and say, I have this 20-page report and it's got all these fancy charts that show my kid learns better this way, I think sometimes, for better or worse, that holds a little more weight with the school and they can feel more confident incorporating those suggestions into an IEP or 504 plan or whatever you might need. I did want to take a second to talk about this kind of situation. This might look a little complicated. I'm going to explain it as best as I can. Anytime you're doing what we would call a standardized assessment, you're always comparing somebody either to their own prior performance or typically to what we would call a normative group. So normative group is just like a nationally based sample. They try to get a good range of age and race and socioeconomic status and different sampling techniques. But you're almost always in pediatrics comparing people to other people their exact same age. So when you look at that pink line, that would be what you would call somebody on a more typical developmental trajectory. So I actually don't like this term cognitive age. It doesn't exist. It's not like somebody with cognitive difficulties, just like a younger person who's typically developing. But for the purposes of this slide, I'm going to talk about cognitive age as if it's a real thing. So in a typically developing person, when they're 3 years old, they're at a cognitive age of about 3. When they're 5, their cognitive age is about 5. When they're 7, it's about 7. And you kind of continue along this trajectory. until you reach kind of your adult level, and then sadly, I'm not twice as smart as a 26-year-old. I might be wiser, I might have more life experience, but your problem solving, your thinking kind of levels out into it at an adult level. For individuals with developmental disability, typically you're always comparing them to the person at their same age. And also some of these differences don't become evident until you reach the level at which those tasks are required. So for example, when you're 3 and you're looking at verbal skills, usually kids are just naming pictures. What's that? Oh, it's a window, it's a sink, it's a teddy bear. As you get into age 21 and you're assessing verbal skills, you're asking, what does this word mean? Explain how these two things are alike. Tell me about this. What is the purpose of this? So you might have higher level difficulties with these inferential, abstract skills that won't be evident until a later age. The other thing is, even though somebody's making gains, they might not be making gains at a typical rate. So in 1 year of time, they might not be making 1 year of progress. That's what you see happening with the blue. So at age 3, they're at a 2-year, 7-month level, but at age 13, they're at more of, I can't actually read it from here, but okay. So, they're at, let's see. They're at about an 8-year-old level and so on. And they might also even reach their higher level where they plateau at an earlier age. So as a result, when you compare someone to that typically developing peer, that's always going to be the normative group, you can have these standard scores go down over time. And what I always want to emphasize to families is this is why scores don't tell the story alone. Even though an individual's standard score is going down, it doesn't mean that they're losing skills necessarily or having greater degrees of impairment. It's just that the gap between them and their same age peers is widening. So, for example, at that early age, a standard score for that blue line might be 90. At age, around 10, it's 75. And then at age 21, it might be around 50. That doesn't mean that this person is not making really good gains in their own development. And these are just gains in the basic cognitive ability. There's other gains that can happen through accommodation, adaptation, changing the environment so that somebody's more functional, even at the same level of cognitive ability. So that's something I did want to point out so that people, if they just get, looking back through the years, looking at scores, it can be a little frightening to see these standard scores change in a way that doesn't seem to reflect your understanding of what is going on. Similarly, you could have the other type of situation where somebody is actually losing cognitive skills for whatever reason. Transitory reasons, developmental reasons, medical concerns that are arising that might be impacting things like, blood flow to the brain, oxygen. In this case, you can have kind of the opposite situation. So at a certain point when that gap between you and your peers is wide enough, you'll reach what we would call a floor for that test, which means that's the lowest score that you get. So typically some of these tests have a mean of 100, but once you hit 50, 45, the score is not going to go lower than that. So if your score stays at a level, you might think that it's staying steady, you're keeping everything you've got, but there may actually be decline going on. And the reason I bring this up is it is something you really do want to mention to your provider if you have concerns about actually losing skills or cognitive decline. There are things we can do to directly assess that. So you can look at raw scores. That's a little dependent on giving the exact same measure every time, which is not always practical. You can look at ability scores, which only some tests have these, but they're basically designed for this purpose to compare an individual's performance over time. And you can look at age and grade equivalence. I don't love to emphasize these scores because they're not very psychometrically sound scores. They can jump around a lot. If somebody's a really good reader and phonemic decoder, in 6th grade, they can get like a 12th grade equivalent for their, nonsense word reading. And it doesn't mean that you can send them straight to college, but I do think that when you're concerned about cognitive decline, if you feel like an individual's motor skills or academic skills are going at a level where they weren't before, that's something that those equivalents can really help you determine. Obviously, if someone was reading at a 6th grade level last year and now they're at a 2nd grade level, that's probably a real concern. So how much time do I have? Am I out? Okay. I'll talk about 2 quick concepts: integration versus inclusion. This is something that's happened kind of historically. It used to be that they would say a child must have the ability to participate in a regular education classroom with only slight modifications. Now, most public school systems have really moved towards more of an inclusion model, which means that regardless of the severity of a disability, a child has a legal right to be educated in the least restrictive environment. So that can be good or that can be bad. It can depend. As a parent, you might not want your kid in a class with 30 typically developing peers because it might not be the right environment, the safe environment for them. So I think it is something good to keep in mind. Schools are under a lot of pressure to maximize inclusion. And it might be up to you to advocate either for inclusion as in the past, or sometimes for a more restricted setting. And then there's always the balance between remediation and accommodation. So remediation is actually trying to make skills better. Accommodating is saying, this is a weakness. We know this is a weakness. How can we work around it? So, if somebody is a wheelchair user, you're not going to just keep encouraging them to try the stairs, try the stairs, try the stairs. They might be doing some activities in physical therapy to strengthen, but you're going to give them the key to the elevator. And there are many accommodations you can do in academic settings, in the home, in community environments to make kids more functional with the limitations that they have. So IEPs, 504 plans, special instructions. I will leave a lot of these to the educational psychologist to discuss as well. Modification within the school instruction, like extended time, reducing homework, help with organization. And then for all of these cognitive domains, depending on where the actual issue is, there's different accommodations you can make. So for attention, everybody knows like, okay, maybe there's medications for attention, but you can also say, sit at the front of the class, reduce distractions, provide a brief cue. Maybe the teacher goes around 5 minutes into a task and taps a kid on the shoulder to make sure they're paying attention, that kind of thing. So for every cognitive domain, there's different recommendations that can be made depending on the pattern of strengths and weaknesses. All right. I think at this point, maybe should we go to questions?
Yes, please. do as in no, please ask questions, not please let's stop talking. I'd love to talk all day. So let me pass over.
Is it possible for a neuropsychologist to diagnose something like Myhre if they are not aware of any of the physical aspects of it?
I would guess not, because they might diagnose the child with a developmental disability, with an attention concern, with a related neurocognitive condition, but they would refer you. I mean, there's been a lot of times where I've been like, have you seen a geneticist? And if not, maybe you want to consider that. Most of our kids, I will say though, do come from genetics, neurology, or cardiology. All those services have genetic conditions at the top of their mind these days. Any kid with seizures at CHOP is pretty much getting a genetic analysis through our engine clinic. So obviously that would be for medical doctors to make the diagnosis of Myhre. But I think, as neuropsychologists, we would be likely to see some of the physical manifestations and wonder if a genetic condition is at play. Does that make sense?
Our sister, who was diagnosed with Myhre after her passing, saw a neuropsychologist in 2016. And so we were wondering why at that point, nothing she was diagnosed with intellectual disabilities, which we
Sure.
already knew about.
I would suspect in the adult world, it is much less likely, I think, for people to be thinking about conditions like this, because when they're recognized at a young age, again, in the natural history, it takes a while. I would guess, I'm sorry to hear about your loss, but I would guess that your sister is among like one of the older individuals who are known to have this syndrome. So I would hope that that is changing. But a lot of people have intellectual disability from a variety of causes, some of them known and a lot of them unknown. So I would not be entirely surprised that that was missed, and I'm sorry to hear that. Sure.
Run up the stairs.
Hi, excuse me. My name is Joy. I'm the physical therapist for Mass General Hospital, and we're finding that a lot of our patients, genetic diagnoses, are not having access to ABA services because they don't have the formal diagnosis of autism. And knowing that there's a higher incidence in Myhre, do you have any suggestions of how to work around, or do we need the neuropsych testing to get that dual diagnosis, or is there other language that we can be telling families of this is when you could qualify for these behavioral services?
Sure. And I guess this is probably where it's a little bit of an obstacle that we have this wonderful autism group at CHOP, because we would not typically be diagnosing autism in our neuropsychological evaluation process. We would be referring folks, what I would consider, and I think most of the autism folks consider the gold standard for autism diagnosis, is the Autism Diagnostic Observation Schedule, ADOS measure. And that's something that's done here by the clinical and research autism folks. So it's a separate type of evaluation. It's much shorter. The waiting list is much shorter, especially if you're under a certain age. Yeah, I'm sorry, in Boston, I know. Although there are a lot of neuropsychologists in Boston, so that might be why Boston kind of is where neuropsychology developed in a lot of ways. So
Angela wants to jump in, and then I think we've got time for one more question.
Just a quick endorsement for neuropsychology. It is actually part of our recommendations for almost every patient that we see. And the point is, it's no disrespect to our wonderful school psychologists, but they are not able to go into those realms. Especially if you work in an environment like CHOP or MGH, you're thinking of special people. Special is our norm. And so we're trying to really characterize what makes somebody special, whereas the school is not allowed to drop hints, right? Am I correct? So just a plug.
I'll come up here. Oh, is this not keeping me fit?
At what point would you recommend, or at what different phases in someone's life would you recommend repeat neuropsychological exams?
yeah, and I was very glad to see Dr. Lynn's recommendation. Ideally, I think the screening at a young age, so especially in the early school age. So I think you said 5 to 8 as, a developmental evaluation initially to establish a baseline. And then what we do is typically see kids back, especially in preparation for transitions. So, later elementary into middle school is one big transition, middle school into high school, and then getting ready to think about, either graduating high school or potentially the ability to stay in school through age 21 with a diagnosis of intellectual disability, vocational training programs, adult living situations that might be kids or young adults might be eligible for as they get nearer to the age 18, 19, 21, when you're thinking about things like guardianship or, social security, like more complex social security, disability, vocational training programs for which you need diagnoses. Because of that, trajectory I showed you guys before, sometimes kids don't meet criteria for an intellectual disability at a very young age, but we kind of get a sense that it might be coming. And so, because those higher level skills, inferential reasoning, abstract reasoning, like the cognitive flexibility, those aren't evident in any kid at a very young age. And those are things that individuals can struggle with the most, as opposed to some very kids with intellectual disability can be they have some great skills. They have some great rote memory sometimes, some great reading and basic academic skills. So I think it's something that you want to continue to monitor as different expectations are placed. I think my slides stop, but I did have a little slide about different expectations and different supports that are available at different ages that might be.
I mean, I think we are up against time, but
Oh, sure.
what Nina has offered, obviously she's here till lunchtime, and she offered before we started this talk that she is very happy to come on and do a special virtual meeting for us. So from today, gather up all those questions and we will hold a special session with Nina and thank her for being part of this family and for her wonderful talk.
Absolutely. Thank you all for the opportunity to speak.
Okay, just before lunch, Bert's on before lunch. So we're fortunate to have Dr. Bert Callewaert here today. He's flown in from Belgium along with his research associate, Eva, who'll be available to chat with you about Myhre research with the poster hall that she has out there. Bert is a pediatrician, clinical geneticist and researcher in medical genetics and is an incredibly valued member of our professional advisory board. He's an associate professor of clinical genetics at Ghent University and the head of the clinic at the Center for Medical Genetics at Ghent University Hospital. He's a senior clinical investigator of the Foundation Flanders. Bit glitchy. His research mainly focuses on rare connective tissue disorders, and he'll be talking to us today about his zebrafish model and his recently published research paper on adults with Myhre syndrome. Welcome, Bert.
Thank you, Kate. Well, it's wonderful being here and finally meeting some of our board members in person, as we had for many years these online meetings. And it's wonderful seeing such a large community that is actually growing and that is supporting research, supporting clinics. That is absolutely wonderful. Thank you for that. So just my disclosures, most of it has been said also by Kate. I'm also a board member for European reference networks in Europe. These are cross-border networks for clinical care for rare diseases. And Ear and Skin is mainly around inherited skin disorders. Ear and Ithaca is about intellectual disability syndromes, autism, and congenital anomalies. I'm a board member of the Belgian Society for Human Genetics, and I'm a member of several patient organization boards, including Myhre syndrome, of course, but also Curie-Slaxa International and arterial tortuosity syndrome. So what is research all about? Well, in the end, of course, we want to improve the care for our patients. For that, we will look at management, but we will also look at potential novel therapies. Also, research is about understanding human biology. That's also a very important point of research. We can do research on Myhre syndrome, and this will give us insights in the pathophysiology or the disease mechanism of Myhre syndrome, but this could also be very relevant information for other conditions. So we have to exploit that research also, that research on rare disease might be relevant for a common disease. And it's also fun, and I get paid for it. So I thought, to start off, I was thinking about making a timeline of research in Myhre syndrome. So actually, before 1981, before the first report of Myhre syndrome, there has been other patients with Myhre syndrome. As long as there are humans, there will have been humans with Myhre syndrome. They were just not diagnosed because the condition wasn't known. So that's actually the first major goal. The first major stepstone was this first report by Selma Meyer. Okay. And then following such a first report, there are many clinical descriptions. Other physicians started recognizing Myhre syndrome, and they kind of start understanding what the condition is like, what problems do we observe in these conditions. And then it took until 2011 to identify the molecular, the genetic cause of Myhre syndrome. That's 30 years. So that's a very long time. And what did we need to identify the gene? We needed novel technologies. Myhre syndrome, these are often de novo mutations. We had no clue which gene it was. There are 22,000 genes. You can start screening them all, but the technology that was available, it was just not possible. 2011, exome sequencing was there. We could screen all the genes and we could find the same variant in several patients. Since then, we have several molecular confirmed reports of patients with Myhre syndrome. This helped us to identify the associated health risks and to provide proper management for patients. And we also saw that there is a clinical spectrum. Another major point, Myhre Syndrome Foundation. People are coming together. A first family described with Myhre syndrome. Natural histories that are now coming along by Angela, by Valerie, and then also by Eva, the first adult phenotyping study with some genotype-phenotype correlations. And along the way, we started to get insight into disease mechanisms. Nicola in Italy is one of those researchers that has done quite some work on this TGF-beta signaling pathway as well. And another major stepstone are the animal models that are now becoming available. I tend to present this with a straight line, but in real life research, it follows its own way. If I hadn't seen this patient in 2019, the first family with Myhre syndrome, I might not have been standing here. So that's how research works. And this is what we see in PubMed, the database of all scientific papers. So the top level is we had 3 years with 10 papers on Myhre syndrome. And in total, since the gene was identified, or since the initial description up there, we are about 80 to 90 papers on Myhre syndrome, which is peanuts, actually. So there is still a lot to do. So are we lazy? Are we slow? Well, let's make a comparison with Marfan syndrome. Maybe you've heard of Marfan syndrome. This is a rather common rare disease, as we call it. It has an incidence 1 in 5,000, 1 in 10,000. It's a little bit the opposite of Myhre syndrome. These patients are rather tall, they are thin, they are hyperlax in the joints, and they develop a widening of the aorta that can be life-threatening and often requires surgical intervention. The first report was in 1896. That's when La Bohème of Puccini went to premiere in Paris, or the first X-ray was taken from the hand of Röntgen. So that was back those days. There were cars already, the firsts. Then there was a whole gap. Nothing happened. Research was very common in these days. Physicians did what they thought they had to do, but it was no real evidence-based medicine. Here, 1991, we identified the gene by Haldate and Claire Francomano. It's a little bit earlier than in Myhre syndrome. Why is that? In Marfan syndrome, we have these large families. And this gave the ability to pinpoint a region in the genome where actually that always segregated with the affected family members. So that narrowed the region down, so you could sequence a very small region to identify the cause of the disease. Molecularly confirmed reports, health risks identified, and so forth. 81, they had the Myhre syndrome, the Marfan Syndrome Foundation. Look at the budget they have. It's a yearly budget. This is a huge undertaking. This is a huge patient organization with, of course, a lot of more means, possibilities, because they have so many more patients. They developed nosologies. I was lucky to be part of the latest nosology. They developed animal models, but then looking at therapy, they didn't advance very far. They have the trials with losartan. They never had trials with beta blockers. They just started giving beta blockers, but there are no randomized controlled trials. There are some with losartan. Some been successful, other been less successful. They also know that some medications should not be given in Myhre syndrome. And I think the major achievement is that they also advanced aortic surgery, and that actually increased the life expectancy from 40s to near normal life expectancy in these patients. But if you compare with the number of outputs, so the top years are 407 papers, this is a huge difference with Myhre syndrome. But still, you can see some resemblances in the past, how this research evolves. So no, I don't think we're lazy, we're just with very few. And I think the trajectory is the same. So actually, what do we need to advance research? Well, of course, we need clinical, critical patient mass. Enough patients will attract more researchers, will attract more funding, will also provide patient samples. So it's important that you're all here together. And we also have to make the bridge to more common disease. This will enable us to attract additional funding for Myhre research. We also need novel technologies. We need exome sequencing to identify the genetic causes initially. We need the upcoming single-cell technology, the animal models. There have been a lot of pharmaceuticals that have been developed over the years that interfere with TGF-beta and BMP signaling. I will tell a little bit about that later. And also novel technologies like CRISPR to perform gene editing. So what will the future look like? First important thing already touched upon by Angela. By gathering all the clinical knowledge, we will be able to provide guidelines. So you will have a doctor that you can take to your doctor and say, this is what I need. Patient empowerment, that's what you are doing now. It's important that you're together. It's important that you have a voice. It's important that you can participate in your own health. We will learn much more about disease mechanisms through animal modeling, and this will be also important for therapy. Small molecules, biologicals, gene editing, and gene silencing. And it's actually technology that has been described in 2012 that made an important start with this gene editing. This is Emmanuel Charpentier and Jennifer Doudna, who actually are microbiologists. And they were observing bacteria in a plate. And they saw that bacteria have specific mechanisms to cut DNA of viruses as an immunological defense against viruses. And so they thought, well, if we can just transpose the system to another organism, we can target any specific DNA sequence and cut it. That was the basis. It's a no-brainer now, but at that time, it was so important that those two women actually made that connection. So this is the general introduction. Myhre syndrome in adulthood, that's the work of Eva I'm presenting now, has been told already, and as you all know, there are a few major things that we need to follow in individuals with Myhre syndrome. So we also know that the number of genetic variants that cause Myhre syndrome are very limited. And most of the variants are de novo, some are inherited. So one observation that I made was, if you look at the GNOMAD database, and this is the most recent version of the GNOMAD database, that includes over 800,000 control people. What does that mean, controls? These are cohorts of individuals that have been sequenced and that don't have overt pediatric disease. So we cannot exclude that some individuals' medical conditions but it was not overt at the child age. And so if we look at the Myhre mutations, we have 7 individuals out of 800,000 that have the 496 variant, and we have 2 that have a variant at 500. So this means that we can expect that about 1 in 100,000 people may have Myhre syndrome. We should be careful. It's possible that these are individuals with relatively mildly presenting disease that has been missed. They don't all have a very careful assessment by physicians or whatever. This is self-reportedly healthy. So we actually wondered, in literature, we have descriptions of about 100 patients, mostly children. So we thought, well, maybe the overrepresentation of the more severe phenotypes. So we thought if we would look to adult cohorts, we might see differences between adults and children. And we might be able to pick up some differences between the 2 affected codons. So if you look at 2 important metrics that we can see, is in the codon 500, stature is a little bit lower, smaller than in the 496. Also, age at diagnosis, there's a major discrepancy between the 2 codons. So this tells us probably a little bit that codon 500 might present more severe and is picked up earlier than those with the 496. This is what we call a radar plot. So in yellow, you see the codon 496, and in blue, 500. And then you have around the radar the different manifestations, and the frequency is actually indicated by on which line the corner ends for each manifestation. And so you can see the surface of the plot as kind of a relation with the severity. And so you can see with codon 500, you have more severe manifestations compared to those 2 with the 496. We also compared literature versus our cohort we assembled. And again, here we see that those that have been reported in literature seems to be more severely affected than those that have not been reported in literature. And that's what we often see, that initial reports are representing those that have more severe manifestations that are picked up earlier than mildly affected persons. This is AI-based technology to make what we call a facial mask. So the facial characteristics are actually being anonymized, and this is an AI picture that is representing the mean of more than a dozen of patients. And also here again, you see the same characteristics for both codons. The codon 500 tends to be a little bit more prominent with the broader midface, the smaller eyes, with broader nose, short philtrum. So based on the knowledge observed in the cohort with adults with Myhre syndrome, we can actually start thinking about guidelines. And this is just a very rough draft that we included in the paper, just as a small guidance, but the major effort we will do the upcoming year together with Angela and with Lois in order to give a more comprehensive overview of the guidelines for management. So for this part, there's large clinical variability. The phenotype seems a little bit more severe in the codon 500 group. And we had a milder phenotype in our cohorts than has been previously reported in literature. Another project we are working on currently is the methylome signature. What's a methylome? Well, you know, you have your DNA, and your DNA contains all your genes. And some genes need to be active at some point during development in certain tissues. You don't want to make liver cells in your eye. So there must be some mechanisms that determine that a liver cell is a liver cell and not an eye cell. And this is actually done by kind of molecular stamps that you can find on the DNA. That's what we call methyl groups, but these are molecular stamps that determine which gene is being used at which frequency. And that we can now easily assess with sequencing, bisulfite sequencing. And this will help us to characterize novel variants. We know of potentially 2 novel variants in Myhre syndrome, outside codon 496 and 500, quite in the neighborhood. So we will assess this also with this signature. Pathway analysis will be possible. And sometimes if a diagnosis is missed on exome sequencing, you can do a methylome signature, and it might as a diagnosis from a methylome signature as well. So how does this work? Well, we look at those regions that have these differences in methylation, so in these molecular steps between control samples from individuals with Myhre syndrome. Then we kind of see how differently, and then based on which reason affected, we can actually make a kind of pathogenicity score based on the differentially motivated regions. And we saw that with Myhre syndrome, we have a very sensitive and specific score that is different from all other known signatures for intellectual disability disorders. The zebrafish model. So just as an overview, it has been touched upon already a few times. So SMAD4 is actually a common transcription factor that is common to both the TGF-beta signaling and BMP, bone morphogenic protein signaling. So what's the signaling pathway? Well, a cell has a certain function to do. But it's like we do our job, we do our function. For instance, we get an order for a company. We will make sure that everything gets done to make the order and actually make the product they want. And then we send out invoices and so forth. These are different functions, but these functions only start when the order comes in. It's a bit the same with signaling pathways. These signaling pathways make sure that the functions are being executed by the cell at the right time. So these BMP and TGF-beta signaling pathways, they provide a kind of connection between the extracellular matrix, so the tissue surrounding the cell and the cell itself. And based on in that interaction, activation of these pathways will behave and how active they are to transcribe their genes in order to execute some functions. So why do we need animal models? Well, if we diagnose a child with a genetic defect causing a genetic disorder, then we would be interested in seeing what's the pathophysiology that results from the genetic defect. Because if we understand the physiology, we can go to a next step, which is therapy. There are new methods, I'll touch on that later in my talk, where we go directly from gene defects to therapy. And that's, of course, why you also need animal models. To understand physiology in animals, we can get access to all tissues. That's not possible in humans. We cannot do brain biopsies in humans. We can, of course, do that in mice, in zebrafish, and so forth. However, it's always important, animals are living creatures as well, that we try to use as less animals, that if possible, that we use animals that are not the most, what we call evolved. So We will not use monkeys to look at brain function. We will try to do that on mice or on zebra or even flies if possible. So to make an animal model, we will need to do a specific editing of the genome to introduce the genetic variant that is present in the condition. And this is why we also use zebrafish. So zebrafish develop externally in an egg cell. And you can visualize this. You can just put it under the microscope and see how it develops. And this is how it looks like. So this is the egg cell. You see the embryo at the border developing. You see the head pole at one side, the tail on the other side. You see the spine forming. You will heart will be developing over there. You can see the eye, the brain between the two eyes. So you can very nicely do this full development. And within 48 hours, you have a fully evolved embryo and you enter the fetal stage. And this is, again, the different stages of the zebrafish. And these are actually the larvae, so they hatch out of their cocoon, more or less. That's out of the egg border, and then here they swim around hours. So they are relatively cheap. They have a lot of offspring, so you can do the statistical analysis easily. They have this external development, they are transparent, and there's quite a high conservation between human genes and fish genes, about 70%. We can apply several fluorescent markers to look at specific tissues. Also, zebrafish have a particular potential to regenerate. So if you cut a fin of a fish, it will regenerate, which is very relevant for fibrosis research. And there is a potential to do compound screening on these fish. So you can have multiple fish that you will treat with a certain compound and see what the effect on the phenotype is. There are some disadvantages. Fish had a genome duplication a few million years ago. So for many genes, they have 2 copies. Might be compensatory mechanisms because of that. Sexual development is completely different in fish and not determined purely genetically, but more by environmental factors. And they don't have lungs, they have bladder instead. So once again, how do we make the model? Well, you know, the DNA is our double helix. And you see all these letters, and C always combines with G, G with C, A with T, and T with A. And just based on this combination, we can actually try and provide the modifications to the DNA. So the DNA is in our cell nucleus, but the protein should be somewhere else, usually, and more in the cell body. So we need the kind of molecule that transports the information from the nucleus to the cell body. And the RNA is just a copy of the sequence of the DNA that is being made. And this will go to the cell body, which produces the protein. So how does this CRISPR-Cas genome editing works? Well, we use a kind of guide RNA. This is a molecule that has a specific sequence complementary to the position where we want to edit our DNA. And with that guide RNA comes a protein that we call Cas9, and this molecular scissor. So the guide RNA brings the Cas9 to a specific position on the DNA, and there the Cas9 provides a cut in the DNA. So what happens when the DNA? Well, there are 2 possibilities. The cell will, of course, try to repair the cut in the DNA, and this can be done by non-homogeneous end joining. So they will just try to paste it together. And this usually goes with loss of one or more of these letters from the DNA. And this is a non-functional protein. The other way is that we also provide a repair template for homology-directed repair is what we call it. And the cell will then use that template to actually paste the cut again. And by doing that, we can incorporate a specific genetic variant. So first method is important if we want to have a protein that's not being made anymore, or a gene defect that doesn't make any protein anymore. This is important for my research because we don't want not to have any SMAD4 anymore. We want that precise variant that causes Myhre syndrome. So how does this work? In the first step, we inject all the components and then we grow the fish to adulthood. This technology is not 100%, so some cells will have the variant, other cells won't have the variant that we introduced. So you get kind of a patchy fish with some cells having this variant, the other ones not. And what we hope is that actually one of the variants is present in one of the either sperm cells or oocytes of the fish. So we cross them again and wait another 3 months until they're adults. And then we can also look if one of the fish might have inherited the variant we want. And that way we have what we call a heterozygous fish. So one gene copy will have the variant of interest in all the cells. We have to cross out again, just in case there would be some off-targets effects. And then we can provide in crosses to get homozygous fish, even so fish that have the variant on both gene copies that are present. And this is what a zebrafish facility looks like. So you have all the different tanks with the fish in it. We have about 80,000 fish, I think, in the facility. So these are the injection microscopes. So this is just with a very fine needle, you can inject the components and the fertilized egg cells. So after a lot of breeding steps, we finally had fish either wild type, so not with a variant, fish with just one variant, heterozygous fish, and then fish that have the variant on both gene copies, the homozygous fish. Why do we make these homozygous fish? Because in human biology, we have ever identified patients with this defect on both copies. Well, fish are not men, and that's something that we see in mice as well. Sometimes you need both copies to be changed in order to get a clear phenotype. So what we did from a first breeding is we looked specific at the vasculature. So these are fluorescent fish in which you can look at the vasculature under the microscope. And we saw that some fish actually lacked a few branches of the aorta that go to the gills. However, this was present in only a very small minority and have additional breeding setting up to compare. We didn't see any difference at 10 days post-fertilization regarding the length. However, when the fish grew older, we saw that the inheritance was not Mendelian anymore. So normally if you cross two heterozygous fish, 25% will be wild type, 25% will be homozygous, and 50% will be heterozygous. If we look at our statistics, we lack fish that are homozygous. So apparently there are a few fishes that would die early. When we look at the length of adult fish, we also saw a clear difference that homozygous fish are smaller. So that does indicate some phenotypes present in adult fish. So this work is still ongoing and is a large part of the PhD of Eva. We will look further at survival. We will look at the morphology of the aorta. And so we have also made other fish within the TGF-beta signaling pathway. So the SMAD3 and SMAD6 knockout fish that show dissection of. We can look at the transcriptome, so which genes are being expressed in which cells. We can look at pathways. That's all established technology. But first, you course, the model. We can do behavioral analysis just by tracking fish in a kind of container with a video tracking. So we can see how active they are. We can see if light has is of importance for their tracking, for their movement. We can see if they shoal together or stay separate. These are all possibilities that we can investigate. We can look at specific single cell to see which cell types are behaving differently. We can look at certain types of brain cells that are important in the pathophysiology of, for instance, autism. Of course, we can test medications. Because of the specific nature of this de novo variant that always occurs at the same position in the SMAD4 gene, there are some specific research opportunities. And again, I thank the Myhre Foundation to acknowledge that and now provide a grant to investigate that further. So I'm very excited about that possibility. So normally in Myhre syndrome, in the normal condition, you have two normal SMAD4 gene copies, and this actually results in normal functioning of the TGF-beta and BMP pathway. If there is the defect, Myhre syndrome defect on one of the copies, we probably see an increase in TGF-beta signaling as well as BMP signaling. So what are the possibilities? We can try to correct the variant directly with gene editing, either by the technology that has been described for the fish is not really possible because you want to have all cells at once to be changed. Prime editing might be the next avenue. We can look at the specific defective RNA copy that is being used as an intermediate between the genetic code and the protein being synthesized. There are technologies to specifically hit these molecules, and we can have developed molecules that will interfere with the pathways. So we need these novel technologies. Another novel technology is iPSCs, or induced pluripotent stem cells. So we take stem cells, for instance, from skin fibroblasts, from blood cells, and we can actually turn the clock back again until they're just an embryonic stem cell again. And these cells, you can make sure that they grow or develop into any cell type you like, for instance, in brain cells, in skin cells, and you can even make small organs out of that. This is the prime editing technology where we will focus on over the coming years with the Myhre Foundation. How does it work? Again, you have this guide RNA that brings your Cas9 to the place where you want it to act. However, the Cas9 is not cutting both strands, but only one strand of the DNA. And you see this large tail. That's actually the sequence you want to introduce. And it's that other protein that is marked with RT that also comes to that specific place by the guide RNA. That's a reverse transcriptase. It will actually copy that tail into your DNA sequence, repairing the specific sequence. And we have some preliminary data also on zebrafish to correct that. Another option would be silencing. It's another variation on a theme. So you need, again, the Cas9 protein. You direct it to the promoter. That's actually the steering center of the gene with a repressor protein that makes sure that there is no transcription from the gene. It's also possible. Other novel technologies are the antisense oligonucleotides that interfere with RNA molecule that messages the genetic information to the cell body. Has been used, for instance, in certain types of diseases, amyloidosis. But what are the problems we will face? One of the things is we are concerned about the cancer risk if we delete one copy. So we rather want to correct the copy than delete it. And the other thing is the therapeutic window. So there is a genetic defect that may cause damage. Fear with growth, cause fibrotic change, and symptoms may be later onset. So we don't diagnose Myhre syndrome in utero for most of the cases. So there might also be some damage, some in development, for instance, of certain cell types in the brain. So the therapeutic window is actually that phase where you can actually diagnose or see symptoms and where therapy is still useful. This is something that is, of course, of concern. On the other hand, we know that fibrosis is a reversible process. So I think that the use of therapy later on will be still beneficial. Also, we know that the brain is an organ that is very, that can actually regenerate as well, partly. So other parts of the brain can take over functions, as you clearly showed. So also there is still potential for improved functioning upon later therapy. So with that, I think it's really time that I end my story.
No.
I would
Bert
like
can
to
tell I'm
thank
putting him
all
under
the
pressure.
collaborators and funds for providing the opportunity to do this this work. And I thank you for your attention.
Thank you, Bert. Mind's blown. Yeah, safe to say we're filling your brains with a lot of information. We can do some quick questions for Bert. Bert is another one of his, obviously over from Belgium, so we've got him all weekend, which is amazing. So, and I've also heard he's rather partial to dancing. So I heard that from another rare disease group. So we'll see him at the disco.
Okay.
But that might not be the time to talk about that. Sure, you never know. Anyone got any questions for Bert?
Thank you, Bert. That was, yeah, mind blowing. So my question is, currently we're only diagnosing, after a child's born and via symptoms. Do you anticipate being able to diagnose?
Thanks earlier?
Yes.
I think so. So we have novel technologies. You might have heard about non-invasive prenatal testing that was typically developed to identify Down syndrome during pregnancy. This technology is evolving rapidly and will probably allow in the future to identify de novo variants. It will be more difficult to identify maternally inherited variants, but paternally inherited variants will also be easily be detected. Technology. That's something that is actually now being used in research setting in order to see if we can actually diagnose these de novo variants. And I think this will come to clinics within a matter of years.
Fetuses that had been, there's at least one fetus that had been, two that have been diagnosed as Myhre, but after birth. But I can tell you there is a paper coming out that will talk about fetuses.
Hey, Bert. Don Clark. I'm live in Somerville, South Carolina. In one of your earlier slides, you mentioned that Myhre syndrome had a distinctive methylome signature compared to other syndromes with intellectual disability. And between your presentation and the previous presentation, I was wondering if, and we still have Nina here, if there's any ongoing research onto the causative function of this MAD4 mutation and intellectual disability, or any working theories, anything along those lines?
Yes, we planning something that's within blocks, I would say, to eventually develop these from iPSCs and develop them both to neurons, so we can look at the function of neurons, but also to glial cells. Why glial cells? These are derived from the neural crests, which is important in Myhre, and also are very important in development of autism. So these are two cell types that we will specifically look at, and then we will try to make brain organoids. So this has been done already for two other intellectual disability conditions that One is recently published, and the other one will follow soon on ZFHX3 and 4, where we develop these organoids. So this is feasible and something we will do within the next few months. It takes some time to research it.
Sure. And an update from our side on that, the IPFPs that Bert mentions, they are going to be with us in August. So we have a 496 and 500 being created now and available. And that's when we talk about those preclinical tools. We at the foundation are enabling researchers like Bert, giving them the tools to be able to advance the science and do so agilely, quickly, efficiently. And they'll be available in August, which is a huge milestone for us at the foundation as well. Any more questions? Because I know it's lunch. We've probably got some hungry children that you need to collect. So one final question maybe, or do you want to leave it there? Oh, one more. Right. Oh, I'm coming.
Hi. So I'm wondering if any of these genetic interventions you're talking about, such as CRISPR or whatever, are they able to apply to, say, an adult or somebody that's already been born that has Myhre, or are these more for a?
Well, that's something that will be part of investigations over the next year. So we will first try to do this in animal models and see how far we can reverse the phenotype. We will, of course, start initially in younger animals, but then we will see if there's still some benefits in older animals. This will take a few years, I guess, in order to do that. The other problem that we have is, of course, you can introduce this technology, but you have to target your cells somehow. So we usually use a viral approach. There are other approaches, nanoparticle approaches that you can use. So, but it's difficult to target all the cells at once. So that will be one of the major challenges. So I don't think this technology will be there within a few years for treatment, but potentially it might become available. I don't know. It's difficult to put a timeline on that, but it's certainly, Myhre syndrome is one of, I think, the paradigm conditions to try and develop such a therapy.
And those types of questions are brilliant, and more of those. Come to a monthly Q&A with Armel. Armel works really closely with Bert. This world is very connected. So we can happily answer those in much more depth. We sometimes are on a Zoom call for an hour and a half, much back and forth. We just open the floor to you all. So really encourage you all to try and come to the next one of those. I will stop talking. Let's thank Bert again for his time. Further ado, a real highlight speaker for us here. Dr. Aaron Dorfman has been a champion of this event, bringing together his colleagues here at CHOP to provide us with these excellent talks. Aaron is the medical director of the South New Jersey section of CHOP Cardiology and the director of New Jersey Cardiology Satellite Operations. He's an attending cardiologist in the Cardiac Center at the Children's Hospital of Philadelphia and is hugely respected and admired by the Myhre patients he sees locally. Welcome, Aaron.
Thank you very much. So first and foremost, I want to thank Kate for organizing, for all of your hard work. And I want to thank Angela for inviting me and for always answering all of my questions when I have them. It's just an honor to work together, both on this and as well as other things that we do together. And it's really an honor to be here today. So thank you and welcome. First, thank you for inviting me to speak in my hometown. And for those of you who are here from afar, welcome to Philadelphia. I am Philadelphia born and bred. I've never really gone anywhere. I've done all my training within like a 2-block radius of here. And so this was a nice, easy ride for me. For those of you who are new to Philadelphia, who have come from a long way, there are some wonderful things you can do while you're here. The Phillies are home this weekend. They're also in first place. They're home this weekend against Cleveland. If you look at the picture in the top left, that's Bryce Harper sending us to the World Series 2 years ago. And that guy in the circle is me in my raincoat, getting poured on and being so happy. We have a lot of history here in Philadelphia. You can see the Liberty Bell, Independence Hall. You could head for a cheesesteak, Pat's or Gino's. You can take your choice. When you go, you can just say that your cardiologist sent you. It's okay. And if you're more interested in the science aspect, this is the giant heart at the Franklin Institute, which is the Children's Science Museum. They have lots of interesting exhibits, but I strongly suggest ignore the brain, spend all your time at the heart. It's the most interesting part of the entire thing. But it's a really cool place, particularly for younger kids. There's a lot of stuff you can touch and move. All right, so with that introduction aside, we have a lot I want to go through, probably too much. So hopefully Kate will keep me on track and so I don't go too long. Because I'm a cardiologist, I need to show you lots of pictures. We like to see things and touch things and look at things. So first, we're going to do a quick review of high school biology as far as how the heart works, how it's supposed to work, and then how sometimes it doesn't. We'll talk about some of the tests that we do in the cardiology world to make, as we talk about the different things that we do, that we're all using the same language. I think there's a lot of sort of words that overlap, so we'll make sure we're talking about the same things. I want to review some of the anatomy of some of the different types of things that we see within Myhre. And then at the end, I'll touch base on some of the recommendations for screening. So first and foremost, by a voluntary raise of hands, you do not have to, this is purely based on your own wishes. Raise your hand if your child has a heart problem that's already needed some type of heart surgery. You or your loved one or the person you're here to support. What about a heart problem that your loved one has a heart problem but has not required surgery? Fair amount. No heart disease, but checks up with a cardiologist every now and again. Some. No heart disease, saw a cardiologist once, and then has never seen a cardiologist. So a nice smattering across the room, but definitely goes along with what we see in that there's a wide range and breadth of heart disease and screening techniques within Myhre. All right, so here's where we get to the PTSD from high school biology. So the way that the heart is built, right? So the heart has 4 major chambers: right atrium, right ventricle, left atrium, left ventricle. The blood goes through the heart twice, right? So the blue blood or low oxygen blood comes back from the body after it delivered oxygen everywhere it's supposed to. It then comes to the right side of the heart where it gets pumped out to the lungs. Once it goes to the lungs, it gets oxygen. That's where it goes from blue to red. And then after it goes from the lungs, it returns back to the heart on the other side, on the left, where it then gets pumped out to the body through the aorta. There's a big wall down the middle of the heart. There shouldn't be any holes in there. And those 2 big tubes that take blood out of the heart, they're called the pulmonary artery and the aorta. Those should be nice and wide open. In the cardiology world, we have lots of tests. We love doing our tests. And depending on as many cardiologists you'll see, we do, that's about as many tests as we can offer. The major things that I'm going to talk about today are an EKG, echo, Holter monitor, CAT scan, and MRI. So EKG, right? So a lot of people confuse EKG and echo. These are completely different tests. The words sound similar, which makes it somewhat confusing. So EKG or ECG, which are exactly the same thing. The K is just for the German cardio with a K, and the C is for the English cardio with a C. But electrocardiogram is just a sticker test, right? So that's when kids you lay down on the table, you get about 12 to 15 stickers on your chest, and then the technician hits the button. And you end up with a tracing that looks kind of like this. It's a bunch of wavy lines on pink paper. And what this helps us look at is the electrical forces in the heart, right? The way the heart squeezes is from electricity, actual electricity that shoots through the heart that makes the chamber squeeze. When we put the stickers on the skin, you can actually measure the electrical forces that are going through the heart through transmission to the skin. So each of those 15 stickers that are put on the chest, arms and legs are looking at the electrical forces through the heart at a different angle. So when you see all those squiggles on the paper, each little segment is looking at a different place where electricity is going through the heart. This is a great screening test. So it's cheap, it's easy, it doesn't hurt. You only have to lay still for about 6 seconds. And so lots of people get EKGs. We do them on almost every patient who comes in for any visit, mainly because it doesn't hurt and it's relatively easy to do. It's a great screening test, right? So if it's perfectly normal, chances are things are perfectly normal. It's really good at looking at rhythm changes. So if the heart is speeding up or slowing down or you're having extra beats, this is a great screening test if you're showing up in the ER with chest pain and you're worried it's a heart attack. And then it's a great screening test for other stuff. So if you're just sort of looking at, might my child or might my loved one have a heart problem, an EKG is a quick, easy, cheap test to say, is there something here that looks suspicious? But in general, it's not going to be your diagnostic test. So echo or echocardiogram is a little bit more of a detailed test, right? So echo is an ultrasound. It's just similar to the ultrasound that OB sonographers use to look at the baby, and that's the way I describe it to the kids that I take care of. It's right, just like when mommies have a baby in their belly, we use the wand and put that on the heart, and it shoots out ultrasound waves that bounces on and off the heart, and based on that, we can actually see the heart beating in the chest. This is what echo looks like, right? So it's essentially a wand that's sending off these sound waves. You can see the white, which is the actual heart tissue. The black is blood going through the heart. And then when we put color on top of that, you can actually see the blood traveling through. So in this patient, there's a little hole in this bottom chambers, and where you can see the blood kind of squirting through that little hole. And the red and the blue is essentially saying which direction does the blood flow. Right? I just showed you on 2 slides back, the red and the blue on most diagrams with cardiology are high oxygen or low oxygen. Ultrasound can't answer high oxygen or low oxygen. It can only measure direction of flow. So the red and blue on here is which direction is the blood flow going. We use echo to look at the way that the heart is built. How thick are the walls? Are there any holes in the heart? Are there any narrowings on the valves? Are the valves leaking? This is a great test. We have them in any cardiologist's office, adult or pediatric. We've got like 3 of them right in the office. In this building, we've got like 20 of them. So this is something it's easy to find. It is not all that cheap, but every office has one. You can usually do it the same day as your appointment. It does require that you lay still for it. So, babies are great because they fall asleep, and teens and young adults are great because they lay down and say, ooh, those are nice pictures. Toddlers are a little harder because they squirm and move and wiggle. And so it can be a little more challenging in toddlers, but that's why we have things like distraction and TVs and things to try and keep kids stable. The other limitation on echo is its ultrasound, right? So ultrasound sees very well through fluid, and ultrasound sees very well through solid. Ultrasound does not see through air. And so when we try and look at the heart, your heart is surrounded by these annoying things called lungs that keep getting in the way. And so when we do ultrasound imaging, we need to carefully place the wand in different places to avoid the places where the lungs are, because we cannot see through air. And so for some people who just have literally bigger lungs, it makes it a little bit more challenging for us to see. Also, as people get older, we're sort of spoiled in the pediatric world, and that the wand is relatively close to the heart. In adults, where there's more bone and muscle and soft tissue and other things that get in the way, ultrasound imaging gets a little bit harder. So as people get older, it gets a little harder to see the heart itself by echo. Another test you'll hear us do is a Holter monitor, right? So these have gotten much smaller, even since I've been in practice, where it used to be this big burly box that you had to sort of schlep around over your shoulder. But now there are these much smaller little stickers that we can put on right in the office or can mail it to your home. And this measures all your heartbeats over a certain period of time. So this is your long-term EKG. So it essentially has 3 stickers instead of 15. You put it on your chest, and then this measures all your heartbeats. You can do this for as little as a day or 2, and you can even leave these on for as long as 2 weeks or a month. And the use for this would be as if you're worried about some kind of heart rhythm problem that comes and goes, where it's not something you're going to catch in the office, but somebody feels sort of, the heart races 3 times a day. So you go home with this, and then you can try and correlate the 3 times a day that they feel their heart beating funny. Is it something we're seeing on that EKG changing? The Apple Watch these days has sort of a less complicated version of this in it. But for most of the things, at least that we see in the pediatric world, things like an Apple Watch or a wearable device don't do the trick. These are much more refined to pick those things up. CAT scan or CTA, right? So if you hear CT scan, CTA, CAT scan, these are all words that mean the exact same thing, right? So this, which stands for computed tomography. You can think of this like an X-ray, right? So if you've had a chest X-ray or an X-ray for a broken hand, right? You put your hand in the machine, they say, hold on, freeze, they hit the button and it takes 1 picture. A CAT scan is essentially it's built in a tube that spins around really, really fast. So while you're laying there, inside that tube, an X-ray machine is spinning around incredibly quickly, taking pictures constantly as it goes. And there's computer software that takes all those pictures and puts them together to generate 3-dimensional pictures of the heart. Advantage of the CAT scan is they're pretty quick. That thing spins really fast. You can take really quick pictures that can be built together. It is X-ray, so there is radiation, and long-term radiation exposure over time is not good. And so we try and limit radiation, particularly in young growing kids and teens. More recent protocols use less radiation, but radiation is radiation. Oftentimes you do need an IV in contrast, and at least in the kids and teens I take care of, they don't love IVs, but it is what it is. And with CAT scan, it's a series of still pictures. So as it's moving around, it's taking picture, 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 and you end up with a bunch of still pictures that you can kind of piece together. This is what CT looks like of the heart. So you can see we can have beautiful pictures in a bunch of different planes, where you can kind of slice it in any way you'd like, where you can see the heart sort of in a front to back, almost like a chest X-ray. You can do it sort of sliced sort of through you, kind of like the magician would cut a person, which is the one in the middle. And then at the end, you can take all of those pictures and slice them together and make 3D models of actually the heart, the structures around the heart, and then the whole aorta, right? So that big line that comes all the way down, that's the aorta as it goes from the heart all the way down to the legs. MRI is kind of it's kind of the funny cousin of CAT scan, right? The images are very similar, and there are many remarkable similarities between MRI and CAT scan, but there are also giant differences in the way that it's built, right? So as opposed to an X-ray machine that spins round and round, an MRI with the first word magnetic, it's a huge magnet that spins round and round. So there's no radiation with an MRI. There's also, as far as we know, no long-term effects if you had an MRI every day of your life. I wouldn't suggest it, but in theory, you can have as many MRIs as you need, and it shouldn't cause any problems. However, it takes a longer amount of time for each picture. So whereas a CAT scan was about 15 minutes, an MRI of the heart is like an hour, hour and a half, which for an adult with no anxiety is probably reasonable. However, for small children, for anxious teens, and even for some anxious adults, laying still for 60 to 90 minutes in a long, thin tube that's like a human-sized paper towel roll can be a little bit intimidating. It is loud, so you get headphones. Some of the MRIs have like a screen in them or a mirror where you can see a screen behind you. Many do not. For cardiac, there's also these like open MRIs you may hear advertised. That doesn't work for the heart because you really got to be all the way in and you need a really powerful magnet. And this gives you similar pictures to CAT scan with the exception of the fact that we can actually see the blood moving through the heart, and we can actually use moving pictures to actually watch the blood cells as they go through the heart, which is useful in certain conditions. This is what MRI pictures look like. So see it remarkably similar to the ones I just showed you from CAT scan, where you can get 3D pictures, slices in any direction. So it's really almost, there are advantages and disadvantages to both, but the pictures are similar. With both of these modalities, you can do things like put them together and spin them around. So this is a 3D reconstruction from a CT scan, where you can actually look at the aorta from a bunch of different ways and sort of see what that looks like. This is another sort of way you can piece the images together, where you're kind of looking at the slices one in a row as you go up and down the chest wall, looking at the heart. With MRI, you can also do functional imaging. So this is what's called respiratory gated. So essentially, and this is why it takes so long, is while you're breathing, what they can do is at the same spot in your breathing cycle. So it looks like the heart is not moving, even though the patient is breathing. At the same spot and while you're breathing, it waits till you get back to the same spot in breathing, and it takes one picture. Then it waits for the next breath and takes the next picture. So it's stacking the pictures one at a time, waiting for the next breath to take the next. So it looks like the heart's not moving. And so with this, you can actually see the heart squeezing and do all kinds of fancy measurements and reconstructions based on that. So one of the questions that always comes up is, should I get a CAT scan or should I get an MRI? And a lot of this is institution dependent. So depending on where you are, some hospitals really like CAT scan, some hospitals really like MRI. Everybody does both, but there's usually a preference for one or the other, depending on where you are. Advantages to CAT scan, it's quick. You usually need no sedation, and it's a little bit more open. And advantages to MRIs, you do get a little bit clearer pictures. There's no radiation, and you can get these more functional, fancy pictures. But MRIs, you have to be able to lay still for 60 to 90 minutes, which either means laying still, closing your eyes and listening to Taylor Swift, or anesthesia. All right, so that's sort of our background. What are the tests that we do? What are the machines that we use? And now we say, now how do we take this and we